Good afternoon from my home here in Sydney, Australia. It is an honour to be asked to speak at your conference today and to provide a global perspective on the challenges in neonatal care. While it would have been so good to have met with you all in Bucharest last year, it is still good that we can connect virtually, and perhaps next year we can meet in person. I have nothing to disclose and no conflicts to declare. I want to acknowledge the organisations that I am fortunate to work with. I'm the current president of the Council of International Neonatal Nurses, and I work as a neonatal clinical nurse consultant in Royal Prince Alfred Hospital in Sydney. I'm a clinical associate professor with the University of Sydney, and I'm an honorary research fellow with the George Institute for Global Health. I want to start my presentation today by acknowledging all my healthcare worker colleagues. In January 2021, the International Council of Nurses confirmed that the deaths in nurses from COVID-19 now numbered more than 2,200, and the psychological impact they're calling mass trauma is immense, with data from many countries highlighting the stress of healthcare workers. Andrew Green published in The Lancet a tribute to some of the doctors globally who have died. The true numbers are unknown as the pandemic continues. Although neonates and children have not been affected as much as adults, the impact globally will affect neonates and us all. The objectives of my session today are to increase knowledge of global neonatal outcomes, where to find global data, and some of the challenges aside from the pandemic, and to understand the importance of healthcare workers in addressing these challenges, and to develop an understanding of the important role of nurses and the Council of International Neonatal Nurses in advocacy and education. I'll start with the Council of International Neonatal Nurses, COIN, and some of the global work that with colleagues we are involved in. I'm privileged to have been the president of COIN for nearly 3 years. This slide depicts our executive board with representatives from 11 countries and is made up of neonatal nurse leaders who work clinically in academia, in education, research, and management. 3 of our board are advanced practice nurse practitioners. The majority of our board have master's degrees, and 8 of us have PhDs. In many countries, nurses are not considered leaders, but as the largest component of healthcare workers, it is imperative that this view changes, and COIN, as you will see, advocates very much for this. So what is COIN? COIN is a global neonatal nurses organisation which started in 2005 with just 3 countries and now has thousands of members from over 70 countries, including 14 national organisations. It was founded by Professor Carol Kerner, who is currently the CEO of COIN. The picture in the top depicts Carol and myself with the Kenyan neonatal nurses launching their organisation in Nairobi in 2019. One of our roles is to support the development of national organisations. However, where there are no national organisations, individuals are welcome to join our community. We collaborate with and work closely with other healthcare organisations, such as the International Council of Nurses, the International Confederation of Midwives, and with our medical college and the International Pediatric Association and the International Federation of Gynecology and Obstetrics, SIGO. And we represent neonatal nurses as part of the Healthcare Professional Association of the WHO PMNCH, the Partnership for Maternal, Newborn and Child and Adolescent Health. This high-level organisation in the bottom picture is chaired by the ex-Prime Minister of New Zealand, and it's the world's largest alliance for women's, children's and adolescents' health, bringing together over 1,000 partner organisations across 192 countries. Since its inception, PMNCH has worked to forge and strengthen partnerships and drive momentum towards the attainment of global targets, and COIN are an integral component of this partnership. Our vision is that all newborns receive high quality care by nurses who have neonatal nursing specific education and skills. And we say neonatal nursing specific education and skills rather than neonatal nurses, as many countries do not have that specific cadre of specialised and qualified neonatal nurses. Much of our work is advocacy around this, and we work with countries to develop neonatal nursing programs. But first, let's start with some good news. This is a global achievement. Neonatal deaths have declined from 5 million in 1990 to 2.54 million in 2019. Neonatal deaths have decreased from 40 to 17 per thousand live births globally, and this is a global average. But neonatal deaths now make up 47% of the under 5 deaths, because the greatest decrease in mortality has been in the under 5s. And not all countries are declining at the same rate. It still means that 2.5 million neonates die each year, which equates to 7,000 per day. And you can see from the map from UNICEF, which indicates visually in red, which countries have the highest mortality. There is inequality between countries and inequalities within countries. If a preterm baby, say a 28-week gestation baby, is born in a high-income country, such as where I live, with immediate access to intensive care, highly skilled nursing and medical care, the chances of survival are much higher than if the same baby were born in a location with no intensive care facilities. It is a sad fact that where you live in the world dramatically affects your access, but also to even essential services. The Sustainable Development Goals are 17 goals that countries have agreed to achieve by 2030. These goals are by design interlinked. SDG 3 is good health and well-being, and within that, it states to end preventable deaths of newborns by 2030 and to reduce newborn mortality to at least as low as 12 per thousand live births in every country. 3.8 is to achieve universal health coverage, including financial risk protection and access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. Very much what we are all trying to achieve, this universal health coverage. I also want to mention SDG 5. This is gender equality, and this is particularly pertinent to us as healthcare workers. Women account for 70% of the health and social care workforce. Yet interestingly, a recent WHO report highlighted that only 20% of global health organizations were found to have gender parity on their boards. 69% of global health organizations were headed by men, and 80% of board chairs were men. We should all perhaps reflect on the gender mix in the boards that we sit on. If you look across the 6 WA regions, you'll see that on average, Africa has the highest rates, with only 3 regions having average below the target of 12. These are average, and there is much individual variation between countries within regions. An example of inequity from my region of Australia. Australia has a neonatal death rate of 2.27 per thousand, but our closest neighbour, Papua New Guinea, which is only 15 kilometres from the tip of Australia, has nearly 10 times our mortality rate. As part of the global community, we need to support countries so that we all achieve the SDGs. And what about WHO Europe? This region is made up of 53 countries, and the neonatal mortality rate ranges from 1 to 23.62 per thousand live births. This is the most recent data, which I accessed in March this year. On the link on this slide, it is possible to identify the rates for each country, if you're interested. An interesting article published by Pop and colleagues in 2020 provided an overview of the Romanian healthcare system. As you can see from the graph, there has been a steady decrease in infant mortality. Now, they report a great variance between counties from 3.5 to 13.1. Romania, as with most European countries, has an average neonatal mortality rate less than 12 per thousand. The causes of mortality are not surprising. Preterm birth being the main cause, intrapartum related complications such as birth asphyxia, infections and sepsis, and birth defects are the four main causes. And these also contribute to post-neonatal mortality and long-term outcomes. 15 million babies are born prematurely each year, and of those, at least 1 million will die. The rate of preterm birth ranges from 5 to 18% of babies born. And what we do know is that 3/4 could be prevented with current cost-effective interventions. Preterm birth complications were involved in 27% of neonatal deaths in Romania in 2016, and the preterm birth rate in Romania is between 7 and 12%, depending on the source and the year of the report. Louis et al. Published a paper in 2019 in the European Journal of Public Health, stating that while the case fatality of neonatal encephalopathy has declined worldwide, the incidence has not changed much, and recommended more research on risk factors to improve prevention. This paper on this slide, published by Fost et al., also in 2019, from Kigali in Rwanda, found nearly 40% of term infants in a cohort of 340 in 2016 had birth asphyxia, again emphasizing the importance of preventative strategies. Infection and sepsis is another main cause of neonatal death. This report, published in The Lancet in 2020 for the Global Burden of Disease study, stated that in 2017 there were 11 million sepsis-related deaths. More than half of all these deaths occurred in children, and many of them neonates, and they recommended more robust infection prevention measures. As you see from the graph, neonatal sepsis in red is a leading cause of death. And from the world map, the pattern of countries with the infants at most risk of sepsis-related death is similar to the previous maps. Congenital anomalies, the fourth leading cause of neonatal death, affect nearly 8 million babies worldwide, and more than 90% of these babies are born in low and middle income countries. 2.5% of the 5.2 million births in the European Union will be born with congenital anomalies. A report just published in The Lancet states that congenital heart disease accounts for nearly 1/3 of all birth defects. And from the map, you can see the countries with the highest mortality rates from congenital anomalies. So globally, we have some challenges. The first is that we must continue to decrease the mortality and morbidity. 2.5 million deaths each year is still far, far too many. And we also have 2.6 million stillbirths per year. And more than 1.5 million neonates survive each year with long-term neurodevelopmental impairment. What is also known is that many babies who die within the first 28 days suffer from conditions and diseases associated with lack of neonatal knowledge and quality care. And this is where us as healthcare workers need to focus. Hospital agreed, saying with his paper from Romania, saying that based on the analysis of the Ministry of Health and Save the Children Romania organization, 1/3 of deaths could have been prevented through programs of support for mothers and children and by the improvement of the equipment of the maternity and neonate departments. This highlights an important aspect that we must focus on the workforce, on nurses, midwives, doctors, healthcare workers, but also having the importance of adequate resources. Challenge 2, the workforce. It is predicted that there will be upwards of 18 million shortage of healthcare workers, and with over half of those nurses and midwives in the next 10 years. But not only lack of numbers, but there is increasingly lack of skilled healthcare workers. The sustainability of the workforce is a global challenge, and we will discuss this more in our workshop. To be safe, you must first have enough staff. In Africa, in a country that in units that I was visiting, one nurse, 45 babies. The one doctor started her rounds and just kept going. Another hospital I visited in another country had between 70 to 100 deliveries a day, had 125 babies in their unit nursery, and 4 nurses and 2 doctors. Globally, we need to talk ratios and think about this in your own units. How many is too many for a nurse and doctor to care for and provide quality care? I work in Sydney, a high-income country. We do not have mandatory ratios for staffing in neonatal units in our state. Only certain states in Australia do. Units are continually short-staffed, struggle with numbers, skill mix, and the retention of skilled staff. It's not just a low and middle-income country challenge, it's a global challenge. This paper I published with colleagues this year, from the WHO and USAID. What is interesting for me is that we were focusing on low and middle-income countries, but the findings are so pertinent to us working in the high-income countries, and the challenges of the quality and sustainable workforce are immense. I don't have time in this talk to go through the findings from this paper, but in our workshop we will discuss these findings. We also published this year a roadmap with the World Health Organization with strategies to help countries with their challenges. And again, we will move to discuss these more in our workshop. But just as an example, Strategy 7, establish strategies for healthcare worker recruitment, well-being, motivation, and retention. Exactly what we have been doing in our high-income countries. So again, although our findings were focusing on low and middle-income countries, they are so relevant to us working in tertiary high-income countries. A sustainable workforce is fundamental to a well-functioning unit. We know this from work by Watson et al. In the UK and from other papers that in-hospital mortality increases when one-to-one nursing decreases. Ratios certainly impact on mortality. This study by Kathara et al. Was assessing missed nursing care due to workload, and I just wanted to show this graph, which demonstrates baby-to-nurse ratios in 3 different types of hospitals in Africa. And this was in Kenya. One of the reasons for dissatisfaction in nurses is the inability to provide quality care because of ratios. And a colleague said this to me the other day. It does not matter if you're the most qualified and skilled nurse or doctor. If the workload is excessive, the care cannot be optimal, and not being able to provide optimal care creates stress and burnout. The 3 types of hospitals in this unit were mission, private, and public. And the public hospital, you can see in the red, the ratios go out to 1 nurse up to 35 to 36 babies. Pre-pandemic, the immigration of nurses and doctors impacted the workforce. Mark et al. Showed the range of salaries for nurses across many countries, which from the table you can see are quite significant, with Great Britain having fairly high salaries and in other European countries much lower, and Sweden having probably the highest. So you can see why nurses travel around and emigrate where they can get better working conditions. The next step in quality care is ensuring that healthcare workers have the knowledge to deliver quality care. Knowledge is made up of components. There must be education based on current research and accurate data and skills. This picture here is teaching the Helping Babies Breathe program to community health workers in Papua New Guinea. Another role of the Council of International Neonatal Nurses, this time with our Australian group, the College of Neonatal Nurses. It does not have to be highly technical. The benefits of skin to skin to keep newborns warm is clear, but education is fundamental to improving care, and we are working with many stakeholders around the world to develop courses and provide education for all levels of healthcare workers. Our COIN competencies have been translated into Russian and are available on our website. And we believe that to meet the complex needs of neonates and their families, there must be uniform qualifications and competencies to support standard knowledge and clinical performance. Our document presents a competency framework for the novice through expert neonatal nurse, and it can be used to guide curriculum development, orientation to the specialization of neonatal nursing, and for performance review, and it's freely available. Many of you will be aware of the Essential Newborn Care course, teaching basic care to nurses and healthcare workers. This is currently being revised, and we are also developing the next level, Care of Small and Sick Newborn Care course, in collaboration with the World Health Organization. This integrates well with the levels of care in the Survive and Thrive document. These 3 levels in this document are useful for countries to use as a framework, and with the World Health Organization standards to improve quality of care. We at COIN are part of the expert technical advisory groups contributing to documents such as these. We also contributed to the standards of care for small and sick newborns. The voice of nurses looking after babies is so important. This is a health system approach to provide quality care, guiding countries in caring for vulnerable newborns in the context of universal health coverage. It defines and standardizes inpatient care of small and sick newborns and builds on the Essential Newborn Care component. Consistent with the WHO Quality of Care Framework, Quality, Equity and Dignity Initiative. We also sit on the revising committee for the Every Newborn Action Plan, with new every newborn coverage targets to achieve by 2025 on the way to the 2030 targets. These targets include the less than or equal to 12 neonatal deaths per 1,000, and also adding in less than or equal to 12 stillbirths per 1,000. These are our targets. The 2025 has 4 targets. If we are to end preventable newborn deaths, we need to ensure that 90% of mothers receive 4 or more antenatal contacts, 90% of births attended by a skilled health professional, 80% of mothers to receive routine postnatal care within 2 days of birth, and 80% of countries to have a national implementation plan. And it's this national implementation plan that includes care of the small and sick newborn. And this is very relevant to us as working in neonatal intensive care. Another important data source is the country profiles for early childhood development from UNICEF and the Countdown to 2030 Women's, Children's and Adolescents' Health. Nurturing care is very topical and has 5 components and encompasses young children's needs for good health, optimal nutrition, security and safety, opportunities for early learning and responsive caregiving. These profiles are an attempt to compile in one place the available data for country and cross-country monitoring and to provide a baseline against which progress can be monitored. Just for these slides, I've chosen examples from Tajikistan, Romania and Russia as examples, but the 2020 profiles, which cover 42 early child development indicators and 997 countries, including high-income countries, 60 high-income countries that encompass 99.8% of the world's children younger than 5 years. The profiles include data on child disability, and there are translations into Arabic, French, Russian, and Spanish. There is now and soon will be a nurturing care framework for newborns as well. I'm going to finish with one important point. We need to work with parents in every country and globally, and I'm delighted to share with you GLANCE. GLANCE is the Global Alliance for Newborn Care. and was founded under the umbrella of the very well-known in Europe, the European Foundation for the Care of Infants, ECNI. This Europe-based organization was founded back in 2008 by Silke Mader and had the aim to make change happen for all families of preterm or ill-born babies in terms of improving care, providing information and support. In 2018, GLANCE was officially registered, and in 2019, the GLANCE founding committee met for the first time to decide on our first global campaign. Our first face-to-face meeting last year did not happen because of the pandemic, but the pandemic, we focused our first campaign very much because of the pandemic on zero separation. And you can see on the slide statements from the committee as a whole, and one I was asked to write on behalf of neonatal nurses, advocating for zero separation of mothers and babies during this pandemic. GLANCE is going to be a very powerful global organization, just like ESCNI, and it is a really good organization if you're not involved with, to become involved with. To summarize, global challenges, and I've only mentioned a few of them, are decreasing neonatal mortality and morbidity. We must work together and support countries to all attain the SDGs. To ensure a skilled, sustainable workforce with the resources to provide quality care, because without this, we cannot achieve the SDGs. And this will be even more challenging following this pandemic. This photo depicts a group of us at a conference in Africa a few months prior to the beginning of the pandemic. It has a multitude of stakeholders. There are nurses and medical students, senior academics from the University of Nairobi, medical and nursing clinicians, non-government organizations, and the World Health Organization representatives. Our separate organizations are strong, but together we are much stronger. And now, even more than ever, nurses, doctors, and all healthcare workers must support each other. In our workshop, Dr. Thompson and I will explore more the need for this sustainable, educated workforce, which all are welcome to attend. Please also contact me for any further information or if I can be of help in any way. Thank you for your time.
So, thank you. Karen, strange to watch yourself talking.
Very strange.
Anyone, any questions? Any questions from the panelists?
Yeah, Karen, Ram here. How do you implement the practices in developing countries with the limited resources, like in Eastern European countries or many other parts of the world, the plans that you are proposing?
Yeah, how are we going to implement them? With some of the plans, we're working with some of our colleagues that are in countries. So in developing educational programs, we're working with colleagues who are sort of on the ground, because now we can't actually travel to the countries to help, but we're trying to work remotely, and we're working with colleagues in Nairobi to set up education specializing course in neonatal nursing and in other parts of Africa as well. It is much more difficult with the pandemic because beforehand we would actually go and be in the country and help, but we're using technology like we all are today and working remotely as much as we can. It's going to be more difficult, and it's going to take us a lot longer, I think. But there's some amazing people working in countries, and with the organizations that we've actually started, we just before the pandemic, we'd launched Neonatal Nurse Organization in Nairobi. The year before that, we'd organized them in Rwanda. And we were just about last year to launch the Zambian Neonatal Nurses Organization. And I think through the organizations, people are finding support and the support to actually develop courses. So a part of what we're doing in the organization is helping with that and working with different partners, the WHO and USAID and others to try this.
Thank you. Katrin, I think Miriam Thompson had put in the chat her comments.
Yeah, but
thanks.
yeah, she can just tell us. Put on your camera, Maren.
Hi, Maren.
She says,
Hi.
Sorry, I'm not prepared to come on screen. You can see I'm in my post-exercise clothes. Sorry, everybody.
No one will see that. It's
I
just
re- well-
reading chats to see the people, I think.
Yeah, I mean, I think for me, a lot of what Karen said can seem not relevant to your own country. However, in the UK, we've really taken on board this need to reduce neonatal death and stillbirths. So we have our own plan to achieve a reduction, which is nationally led, but very locally driven as well. So our target is to reduce our neonatal deaths and stillbirth rate by 50% by 2025, which is actually quite a big undertaking, given the fact that over the last 10, 15 years, we've made little tiny impacts on it, but not as big as we're trying to make. And actually that we are already seeing benefits. So I think we've really, trying to grasp and move this forward. And I was just interested to know if any other countries are having the same sort of effort.
I think in Australia we are too, Maren. We're looking at bundles to decrease our stillbirth rate. And certainly our mortality rate isn't high, but compared to other countries, but still we're looking at ways to actually reduce it. Ram, sorry, you were going to say something?
Yeah, given the changes in demographics in most of parts of the globe with migration, immigration, are we seeing changes in the stillbirth rates, or because of the migration of people from low-income countries to, for example, to UK, or in US, we still have a very high mortality.
We do.
Yeah.
Mm.
What do you
Yeah,
see?
I think in Australia, our stillbirth rate and mortality rate are not high, but as I said in my presentation, Papua New Guinea is so close to us. It's like 15 kilometers off the top of Australia, and the mortality rate and the stillbirth rate is incredibly high. So I think for us, we have a responsibility to actually help there as well in countries that are close to us, as well as around the world. And certainly it's areas that we're working on. It'd be interesting to see the impact of the pandemic as well on our stillbirth rates, our mortality rates around the world.
And certainly in the UK, we've recently had our maternal mortality report published, which like the US shows there is a real, you're 5-6 times more likely to die as a mother in childbirth or in the first year after you've had a baby, if you're from a Black or ethnic minority group, than if you're white. And that's really sobering. And I think, some other European countries will find the same things with their migrant populations, etc. Katrin, do you know anything for Austria?
Yeah, we're just analyzing the data. So for us, no big change actually. We have seen the same prematurity rates. So we did not see any decline. So also for the stillbirth, no big difference so far, but not all data are looked at, and we try to do it really Austrian-wide. So the first analysis did not show any difference, interestingly, and we also on the units didn't see a big change. So probably not in Austria, because Denmark had a pretty severe decline in prematurity. So interesting. We cannot tell why in some countries and in some countries not. Probably we now go to the workshop, and unfortunately it will not so interactive as we would like it to have it due to the circumstances. But we will have 3 presentations, and we will have short discussions after that, and then a bigger discussion at the end. Hopefully we will time for that. So please, Adrian, start.
I would like to thank to the organizers for inviting me to this important meeting, and also I would like to thank them for showing me the topic that I like very much, the brain-focused neonatal intensive care. First of all, I want to challenge the aim of the neonatal intensive care, which in the past has been survival of the newborns, intact survival of the newborns. And I will tell you that nowadays, due to progress in neonatal intensive care technique, the aim of the neonatal care should be preservation of the brain function and optimal neurological and developmental outcome, as Professor Rosen told us many years ago. The brain-oriented intensive care treatment is not a new subject. It was first stated in an article in 1982 by a Swedish group related to the neuroprotection in the case of severe asphyxia. More and more centers looked at this way of taking care of the newborns. And so happened that more than a decade ago, several centers in the US organized what is called now neonatal neurocritical care. That means a subspecialty whose goal was to implement neuroprotective strategies, continuous bedside monitoring of neurologic function and therapies in order to reduce the risk of neurologic injury and improve the long-term neurodevelopmental outcomes in neonates who need intensive care. As you can see, it is not said, and I will come to this later, neonates with neurologic conditions. What would be the frame of such a program of brain-focused neonatal intensive care? I will share with you first my view of such a program. Then I will show you examples of cases in which brain-focused neonatal intensive care was important in managing the patients. And in the last part of my talk, I will speak about the family-centered care and its impact on neurodevelopment as an integral part of the brain-focused neurointensive care in the newborn. The four pillars on which a program of brain-focused neonatal intensive care stay would be history, evaluation, interventions, and outcome. And first of all, we will go to history. And I will begin by telling you that a program of brain-focused neonatal intensive care should have a fetal neurology component, because the development of the brain begins in day one after conception and continues throughout the childhood. So as Professor Scher told us several months ago in a presentations in the Newborn Brain Society, it is important to have in mind the first 1,000 days of the newborn and to take into account the fetal part of the brain development. Always look at the fetal brain and always make the fetal neurology colleagues as part of your team. Then we go to the evaluation, and we begin with the first of the three steps of evaluation. This is neurologic assessment. And you will have neurologic examinations, and I put here for you the Amiel-Tisson neurologic exam for the newborn, but you can use also the practical examination or the Hammersmith examination, specific examinations made to work in the case of the neonates with neurological conditions, both term and preterm. And then there will be the scores, the Thompson score or the modified Sarnat score, which allow you to stratify the risk of the babies with, for example, perinatal asphyxia in order to include them in neuroprotective intervention. The second part of the evaluation is the neuromonitoring, and this has been one of the most important steps forward, allowing us to build neonatal brain-focused intensive care programs. We have now two means to look into the brains of the newborns. The first one would be the evaluation of the electrical activity of the brain by the way of EEG and by the way of continuous CFM monitoring, cerebral function monitors like the AEEG. And the second mean will be the measurement of regional oxygen saturation in the brain that will allow us to make assumptions about the brain oxygenation, about the brain metabolism, and about the cerebral blood flow. The third and very important step that also had evaluated a lot in the last couple of years is the neuroimaging. And I will stick to the two imaging modalities that we use in our units. Ultrasound, that allows us characterization, multiplanary characterization of the lesions. You see here classic anterior fontanel ultrasound and an ultrasound image taken through the mastoid fontanel, and also the capacity to look in real time at the vessels, like the Doppler examination of the cerebral circulation in a newborn. And of course, the MRI, which gained more and more place as the gold standard in evaluation of the newborn's brain. And you see here classic MRIs and also MR angiography. So this will be the first two steps, history and evaluation. Then you go to intervention based on what you've discovered. And the first intervention I will speak you about is neuroprotection. And I should begin here with therapeutic hypothermia. Those are the two studies, the two classical studies in the field, the American and the European study. And I should say that this is the first intervention that was proven to be beneficial in the treatment of prenatal asphyxia. But neuroprotection is not just therapeutic hypothermia. And I will see it as developing good evidence-based and efficient guidelines for management of seizures, for example, or for management of post-hemorrhagic hydrocephalus, to which I will refer in the future slides of my presentation. The second intervention is what we call care bundles. Care bundles are interventions, multiple interventions, small things that you do in order to prevent the occurrence of certain pathologies. And the best example we have is the care bundle that aims to prevent interventricular hemorrhage in the preemies. Head on the midline, a little upwards position of the head, and little manipulation and avoidance of rapid blood sampling. But there are also other care bundles that are developing now. Another intervention on which we could speak is the brain-targeted interventions, like brain-targeted ventilation, a ventilation that takes into account the effects of mechanical ventilation on the brain, and I will give you an example later. And last but not the least in the intervention, there is the pain management. And we should remember this new article from 2019 from McPherson that's discussing the impact of both acute and chronic pain on the neurological development of the neonates, especially of the premature neonates, the means that we have to evaluate it, and the treatment options for these symptoms that we many times neglect in the neonatal intensive care unit. Now, we should say that the neonatal intensive care doesn't end at the discharge from the hospital. And the fourth very important step in brain-focused neonatal intensive care is the follow-up. And I won't touch on follow-up on my lecture because the next two lectures will be focused on follow-up. Just, I would like to let you know that each case I will present will have a follow-up component. And now we are getting to the bottom of the framework of neonatal, brain-focused neonatal intensive care. And the very important step in this framework is the family-centered care, which I will show you has a huge effect on brain development and on neuroprotection. And it's an easy thing that we can all do in our units. And don't forget about the team. Don't forget about training. And this is a classic article on developing a training program in AEG. This is our training programs. We have 2 courses of neuromonitoring and neuroimaging each year, and I will kindly invite you to join our courses whenever you like. It's there are 6 weeks courses in which we will discuss all these aspects more than in half an hour. And also don't forget to teach your team how to speak with the parents. And I will recommend you this Our Hope approach, which means reflection, humility, open-mindedness, partnership, and engagement with the families of our little patients. And don't forget the psychological assistance for your team, because you have stress in the neonatal intensive care unit and more stress in neuro-NICUs. So you should evaluate, as we did, the impact of stress on the personnel and develop interventions aimed to ease the stress and to prevent the burnout syndrome in these units. Having this said, and having framed the picture of the brain-focused neonatal intensive care with history, evaluation, assessment, neuromotor neuroimaging, interventions, neuroprotection care bundles, brain-targeted intervention, pain management, and follow-up, all centered on a family-centered care program and taking care of our team, we should see who will benefit of this brain-focused neonatal intensive care. As I told you, more than a decade ago, units in the US began to develop neuro-NICUs. And the first unit was that in UCSF, and one of the second unit was that in Stanford. And they published their data. And surprisingly, they have seen that more than half of the newborns admitted in the neuro-NICUs had non-neurologic diagnosis. They were preemies, small preemies, they were babies with heart diseases, they were babies with surgery, all having the brain secondary affected by the neonatal pathology. So my advice and my take-home message for you is brain-focused neonatal intensive care is for all the newborns, not only for the newborns with neurologic condition. And I will try to make you understand this by presenting you a couple of cases of babies with both neurological and non-neurological diagnosis. And let's go first to the simple things, you think. The babies with neurological diagnosis. And I will show you two special cases, interesting cases of babies with neonatal seizures, in which a brain-focused approach helped us in diagnosis and management. The first one is Sebastian, a term newborn, born vaginally with an Apgars of 3, 5, and 7, with a mother that had fever prior to delivery, with a good blood gas, but who was hypotonic after the delivery and had AEG after having blood culture drawn and acute phase reacted also determined. And we began the treatment with antibiotics. So he had AEG monitoring since 3 hours of life, and we have seen electrical seizures, upward deflection of the upper and lower margin. We treated them with phenobarb. We got the baby into birth suppression, and then the seizures reoccurred, and we gave again phenobarbital. And then the seizures reoccurred, and we gave phenytoin, and we succeeded to stop them with levetiracetam, loading and maintenance dose. So here you have the guideline I will propose you with neuromonitoring, phenobarbital, 2 doses, then phenytoin, levetiracetam, and continuous neuromonitoring to see if the seizures stopped. And you remember, assessment, monitoring, what comes next? Comes imaging, neuroimaging. The ultrasound was normal, but the baby had seizures, so we had to go further and see what's in the brain that's causing the seizures, because they were not related to that infection, but we didn't know what it was. And it was a surprise, because on the Titu image, we have seen here a parieto-occipital vascular malformation on the meninges and hemosiderin deposits in the brain. You see here an SWI sequence, you see better the malformation. What was the outcome of Sebastian? Sebastian is now 2 years old. He had therapy with levetiracetam until 2 months of life. And the EEG was normal at 2 months, so we stopped the anticonvulsants. And now the baby's had another normal EEG at 1 year. From the motor point of view, he developed hypotonia, then hypertonic, head control at 2 months, sitting at 1 year, so delayed milestones, even if he was doing physical therapy. He walked independently at 1 year and 4 months, and he's clumsy now when running. head circumference in the lower limits of normal, strabismus, operated, and now deficit in expressive language. He's doing physical therapy, language stimulation, and he's followed by us and by the neurosurgeon. The second baby has a similar story. Dennis, born at term, vaginal delivery, clonic seizures that responded initially to phenobarb, and then they were treated with levetiracetam. What we noticed then, though, by monitoring with AEG, it was that the seizures were unilateral on the left. So we did an ultrasound and we saw a hyperechogenic image in the external angle of the frontal horn of the left ventricle. And on the right, we saw a cystic image, so two lesions with different ages. The image was suggestive for an infarction, but we have seen this, as you probably know, not as much in the term newborns, but in the preterms, having intraventricular hemorrhage. So it took us to think about a venous infarction. Also, we observed a narrowed bandwidth on the right, which was to be expected because of the cystic formation, destruction of cerebral substance on the right. So what did the MRI show us? We see this on the left and the cyst on the right, but also we see hemorrhage in the caudate nucleus bilaterally. And when you go to the SWI sequence, we see the venous distribution of the infarction. And also we see here a thrombosis of the superior sagittal sinus. So sagittal sinus thrombosis, always think about it when you see a peculiar hemorrhage in a term newborn, a hemorrhage that doesn't have to be here. Usually you find them in the thalamus, but this time you found it in the trajectory of the terminal vein, and they were with different ages bilateral. What happened to Dennis? He's still on levetiracetam. He was not sitting independently at 6 months, but he was sitting at 9 months. He's not walking at 1 year. And the head circumference is a little bit on the lower percentiles of the normal. So deficit of head growth, which was to be expected due to the lesions that were there with the loss of cerebral substance. But as I told you, brain-protected, brain-oriented neonatal intensive care is not only for newborns with neurologic conditions. So we go now to babies with non-neurologic diagnosis. And we go to the most frequent admissions in the NICU, the premature infants with RDS. And I will present you a couple of cases. The first two will be very interesting. Meet Farid, born at 31 weeks, 1,700 grams, Apgar 2, 5, and 8. He was intubated from the delivery room. He was given surfactant. The mother has 10 miscarriages between 13 and 21 weeks, had a vaginal prolapse, had hypertension, and had contractions for the last 24 hours. So it was a miracle that the pregnancy could be taken thus far. And here you have the cerebral saturation curves for the first 7 days of life of Farid. And what can you see here? The cerebral saturation is huge variations in the cerebral oxygen saturations. And what would this herald? This will herald nothing good. It's a huge variation and is probably occurring because of the lost cerebrovascular autoregulation. So we know from books what happens in this case. But now, as you can see, we can see it in the real life with our monitors. This is the first ultrasound, and this is the ultrasound at 3 days of life with a grade 3 intraventricular hemorrhage that evaluated the grade 3 hemorrhage, bigger hemorrhage bilateral by 5 days. Usually after 5 days, things cool, like a cool in the brain. So there is no autoregulation impairment. and then the baby evaluated to progressive ventricular dilatation. So we had a baby that had impaired cerebrovascular, impaired CBF autoregulation, that developed hemorrhage and progressive ventricular dilatation. And we managed it according to the new protocol of management of post-hemorrhagic ventricular dilatation, published by this group last year in Journal of Pediatrics. Protocol that took into account the first research in this topic that was done by the group of Linda de Vries in Utrecht many years ago, that stated that early lumbar punctures could prevent the occurrence of post-hemorrhagic ventricular dilatation. So what we did is that when the baby got into yellow zone, as you will see, this is the ventricular index. When the baby got here, we did evacuatory lumbar punctures. This is the first lumbar puncture, before and after. This is the second lumbar puncture, before and after. And as you can see, the ventricles stabilized after those two lumbar punctures. By 37 weeks, the ventricular diameter stabilized. This is at 60 days, and this is Farid at 4 months. Had control, but a hypertonicity of the legs, so he's doing physical therapy, but the head circumference was good. And now I'm going to present a baby with the same history, but with a different pathology. And this is Steven, in Romanian Ștefan. He's a good friend of mine now. He's 2 years and a half, and he wants to be goalkeeper in a football team. What happened to Ștefan? He was born at 31 weeks with low Apgar scores, SIMV, surfactant, intubated from the delivery room, the same history. What was different? This is the cerebral oxygen saturation of Ștefan. And you can see it's constant. There is no impaired autoregulation of the blood flow. So the baby had a little bit of ventricular dilatation from delivery, no hemorrhage, good head circumference, head control at 2 months, hypertonicity of one leg at 6 months, slight hypertonicity that it's okay-ish now. He's still like clumsy when running with the right foot, but he's doing kinetotherapy, and language and cognitive is normal. So again, Steven and Farid, you see, this is good blood flow, this is impaired autoregulation. We won't know this if you wouldn't do brain-focused neonatal intensive care. So is it usually like this? Yes. Our group published in 2011 a study showing that lower SiO2 during the first 24 hours of life was significantly associated with motor deficits and with lower score in the Bailey test. And also, we showed that variations in the cerebral oxygen saturations were associated with problems at both 40 weeks corrected age and later in the cognitive and the motor development of the babies. What about bigger babies? Do they need CFM? Let's see. This is Noah, who had respiratory distress, a big baby from a diabetic mother that was intubated at 4 hours of life due to failure of CPAP. And this is surfactant administration with the depression of the tracing. And here is a small seizure. And here you have a burst suppression rhythm, probably because sedation with fentanyl. Fentanyl, a drug that we use here, and this is the usual dose, can have those effects in the babies with, ventilated. It's decreasing the continuity of the tracing. And as you can see, we decreased the fentanyl dose and we obtained good sleep-wake cycles in this baby, even if he was sedated on the vent. And this is what you want to have the baby on the ventilator with a level of sedation that allows the presence of normal sleep-wake cycles, avoiding a depression of the tracing. And I will come to this later. Another example is Radu, a baby with congenital pneumonia who was intubated at 18 hours of life due to progressive respiratory distress. This is his regional oxygen saturation, cerebral regional oxygen saturation curve. What happened to Radu? He had hypercarbia that produced vasodilatation and increase in CBF with increase in regional saturation. Then we administered surfactant and we ventilated him. And he developed again hypercarbia. So again, increased blood flow. Put the baby on high frequency oscillatory ventilation. And we kind of succeeded to maintain the CO2 at normal levels. Is it over? No, because the situation improved and there was a decrease in PaCO2 that produced vasoconstriction, and we had to switch the baby on CMV, and we extubated him here when he was ready, and he was well. Good head circumference and good head control. He follows, he touches the object with his hands, opens the fist, so what normal should do a baby at 4 months. And this takes me to the brain focused mechanical ventilation. Actually, I would dare to say brain and lung focused neonatal ventilation. What you should do, you should monitor the CBF when ventilating a baby to see the variation in the saturation, the work accordingly. You should avoid high PEEP because it will decrease the CBF. You should avoid permissive hypocarbia because it will increase the CBF, and you should avoid hypocapnia. So common sense things, but now we see the consequences of our therapeutic interventions on the brain. We have also other situations in which neuromonitoring is helpful, and this is the decision to transfuse a baby, both acute and chronic, and the sedation on the ventilator, which we've discussed before. What about the transfusion? We should here also change the paradigm, and we should think of anemia as the situation in which the organism couldn't get the oxygen that he needs, and the organ couldn't get the oxygen, extract the oxygen that he needs. And the first adaptive behavior of the organism that's not getting enough oxygen because there's not enough hemoglobin is to extract more oxygen of what he has. So it will be a high fractional tissue oxygen extraction, and it will be a decrease in the cerebral oxygen saturation. And it's what we observed in these cases. This is an umbilical cord hemorrhage, and this is a pulmonary hemorrhage in which we transfused early based on the increase in fractional tissue oxygen extraction and the decrease in cerebral oxygen saturation. And the prognosis in both cases was good. This baby is 3 years old. This baby is 2 years old. I've seen them in the follow-up clinic and they are okay. What about anemia of prematurity? Here things are more simple. If you have a cerebral saturation under 55, yes, like this baby, and the oxygen extraction of 42%, even if you have a good hematocrit, probably due to this study, you should transfuse this baby because the oxygen delivery capacity to the brain is decreased. What about fentanyl? As I told you, fentanyl makes the baby go in burst suppression and could provoke paroxystic electrical activity. So you should titrate the fentanyl to a moment when you obtain good EEG tracing. And now I will switch to the last part of my talk and speak you about a very dear subject, the family-centered care in the concept of brain-focused neonatal intensive care. And I will ask you, does it help? Yes, because you have short-term benefits, and you will see them, and long-term benefits as improved neurological outcome. And we studied the effect of skin-to-skin care on regional cerebral and peripheral oxygen saturations and stability and values in the premature neonates. And we had two groups. Those were in skin-to-skin care, and those were in the incubators. No difference in between the babies. And you see that the oxygen saturation is higher, significantly higher, in the babies in skin-to-skin care group, and there was no difference in the temperatures of the babies. And also, more important, the variations of the cerebral and splagnic saturation were lower in the group of babies cared in skin-to-skin care. So our conclusion was that the cerebral saturations are higher in the normal range and more stable in babies cared in skin-to-skin with their mothers. Also, we noticed a decrease in the incidence of the apneic spells in the groups. What about of long-term consequences? The babies that are cared in a family-centered unit, like here we have a ventilated baby in his mother's arms, here we have a baby on CPAP, and here we have, this is a picture very dear to me, twins in daddy's arms. What did we notice compared to this category of babies? That the duration of stay in hospital is lower, the number of readmission is lower because the mothers get more proficient, and as you see, the cognitive scores are higher in babies cared in a family-centered approach. And this is consistent on what is known now, that a very good and stimulative family environment could get to a better neurodevelopment of the babies. And we can begin this in our NICUs as a brain-focused intervention. So, in conclusion, we have the means. Actual techniques of assessment and monitoring allow us a good evaluation of the central nervous system in the neonates. We have the interventions, and we should offer equal importance to cardiorespiratory and neurological care in the newborn. Who is the candidate? Everyone. As I showed you, things happen in all the brains of the newborns in the NICUs, and we shouldn't pay attention only to those with primary neurologic diagnosis. So brain-focused neonatal intensive care should be available for all the newborns. And finally, by looking at the brain, we could improve the outcome of our little patients. I would like to thank to all my colleagues, to all the team that made a program of brain-focused neonatal intensive care possible. The Department of Maternal Fetal Medicine, the Department of Radiology, the Department of Neonatology, the Physical and Occupational Therapy, which begins in the NICU, and my colleagues in the intensive project that evaluated the stress of the members of the teams. And last but not least, I would like to thank to all our small patients and their wonderful families for their contribution to a program of brain-focused neonatal intensive care. Thank you so much for your attention.
Thank you very much for this very interesting talk. We thought about asking questions now after all these presentations. So
I don't know why I cannot come on video.
Okay, so you're hearing us. That's important.
Yes, yes.
So I have some questions here in the chat. So about a practical question about lumbar puncture. In case of hydrocephalus, what amount of brain fluid would you drain, for example, in a 1,000 gram baby?
I will say I won't drain very much one time. So no more than 10 ml per kilogram. And as far as it comes, okay? And you do ultrasound before and after the puncture. So you can do 2-3 lumbar punctures, and then if the things are not going well, you should go to neurosurgery, because if you don't succeed after 3 lumbar punctures, you should go to install a reservoir or a shunt. So my answer is no more than 10 ml per kilogram. Don't be greedy and try to take very much. Actually, the aim of the lumbar puncture is to make the fluid more fluid, to get the proteins out, not to take the fluid out.
And actually, there was always big discussion about these lumbar punctures. But with this new recommendation guideline now, I think we would do this lumbar puncture earlier than before, because there are some Cochrane data out there that it's not working when there's already hydrocephalus. But if you really start puncturing these babies when they are reaching 97th percentile, this is pretty early in the course. At least that's my experience, that we are now earlier in the course and now we are getting blood and liquor much easier out. Is the same experience for you?
Yes, this is the same thing we do when we got to the 97th percentile. You have seen there are the curves, and the yellow actually is 97%, and you have curves for the Levin index, but also for anterior horn width, which shouldn't be more than 6 millimeters, and for the thalamo-occipital distance, which is I think about 45, about 25 is the maximum. But I'm not using the thalamo-occipital distance. I'm using usually the Levin index because this is going is evaluating according to the gestational age. As you know, it's the only one that's increasing or decreasing.
And would you think also neuromonitoring helps in these babies? Because that's my experience, that the
yes,
is getting
yes,
worse,
yes,
and the AEG is getting worse, and so
but
it helps, I think.
You know, I'm sorry to interrupt you. You know that it's not time to wait until you see modifications on the nears. So
Yeah.
actually, now we are trying to do something before it affects brain circulation or brain activity, because this is the aim of the early lumbar punctures. You do something before. I'm sorry, you do something before.
Sorry, no, actually, I like the data of the Elvis trial, for example, where they couldn't really show so much difference in the neurodevelopmental outcome, unfortunately, but at least they have the lowest number of VP shunts ever published. So I think getting out these blood and blood clots early in the course would probably reduce the need for VP shunt. And we all know that one infant without an VP shunt less in our unit every month or year, it's worth it. So actually, the people are worried because there are so many data not showing any efficacy in hydrocephalus treatment. But I think if it's early in the course, it's different.
Okay, I have two more questions to answer.
Yes,
okay, first to Dr. Jamal. Those babies I showed you were babies in a very severe state. So the preemies were with RDS and needed surfactant, and the other one, the term baby had a congenital pneumonia, and in our experience, it's consumption of the surfactant in this pathology. So I like to give surfactant to them also. So this is why because I have babies in which we don't give surfactant, ventilated babies in which we don't give surfactant, but we tend to use it more and more in term newborns with pneumonia or with meconium aspiration. We tend to use them more and more because we think of the secondary surfactant deficiency. So this is the answer to the first. And to the second question, skin to skin care was not continuous, was intermittent. So because the mother couldn't stay 24 hours with the baby in the NICU, we have an open bay NICU. And this is a long discussion, why keep it open bay or why keep it individual boxes. So it was intermittent, but they spent most of the time with their mothers. And it was very well received also by the nurses. Okay, and another question, I'm sorry, they keep coming. Another question is about the drift protocol. If you ask me, this is very personal. I think the drift deserves more attention than it was. I think actually the study showed some good results. And probably we should see why the hemorrhages happen, because the principle is the same, is to get the fluid more fluid, to decrease the viscosity of the fluid. Actually, it was the same principle. So maybe, I don't know, maybe less artificial fluid, maybe another concentration to avoid, maybe we take too much too quickly, and this is why they are bleeding. I don't know. So yes, I think the drift deserves more attention. if you ask me, yes, I don't see another question. Let me
I
see.
think there are some questions also in the other chat, but due to
No,
time
to
reason, maybe
time.
one. Yes,
Yeah.
time reason. I would
Okay.
say answer the question in the chat, and if we have time afterwards, then we can go back to that. It's okay for everybody?
Yes, yes, yes. The answer is I just answered to this question to
Yeah, so just
the
answer in
10 mLs.
the chat, and if we have time afterwards, we can discuss.
Okay, and I will answer to all of them in written afterwards.
So thank you everybody, and yeah, I'm great that there are so many questions, but now let's go continue. Okay, thank you very much for your interest and in this workshop, and I'm very pleased to be invited to talk about neurodevelopmental outcome of preterm infants, and I'm really looking forward to our discussion after this. So what do we expect regarding to neurodevelopmental outcome of preterm infants, and why is it important to assess it? What should be assessed? When should it be assessed? Which methods can be used? What are the pitfalls? What are difficulties? And how is comparability of the data? And which factors do impact neurodevelopmental outcome in preterm babies? So that's all I want to share my thoughts about that. And I'm really looking forward to a discussion in the end. So what do we expect? Actually, when we hear the history of twins born at 25 plus 3 weeks of gestation, they had a C-section due to increasing infection in the mom and beginning labor. Twin 1 had a weight of 716 grams and an APGAR score of 899, 7.28 cord pH, but congenital infection, 14 days on the ventilator, and an IVH grade 3 on both sides with an posthemorrhagic ventricular dilatation, needing an external drain initially, but no shunt on the long run. There were seizures during hospital stay, but no epilepsy later on, and no other morbidities. The other twin, born with 835 grams with an APGAR score of 889, 7.4 cord pH, 2 days on the ventilator, and no other morbidities. So what do we expect? Actually, I would like to show you a short clip of these infants later on, but I think we should really think about how will an outcome of these infants look like? What do we expect? When will we be able to tell? And what other factors will influence the outcome of these infants? So that's what we all have to keep in mind looking at these babies. This is just to resume how we define outcome usually with developmental tests, and we will talk about this later. There are different tests used, but usually the normal outcome is defined as a score around 100 plus minus 1 standard deviation, which is usually 15 points. And mild impairment if there's a minus of 2 standard deviations, moderate if it's more than 3, and severe impairment if it's more than 4 standard deviations below the normal or mean outcome. So that's what usually is used, but of course with different tests, different definitions can come apart. Some people also try to combine cognitive and motor into one kind of outcome definition, and also probably neurosensory data are included. So it's not so easy to compare all these data. That's what we have to keep in mind. So these composite outcome definitions and scores which are used are really difficult to compare. So always try to read what is used, what test was used, what definitions are used. So here the clip of these two twins born at 25 weeks plus 3 days. And you probably remember that one of the infants had an IVH grade 3 and an external ventricular drain, and the other one not. So actually, just from these short clips, you probably might not be able to tell who is who. And I would like to ask you, is that what you have expected? So it's not always easy to tell. So to show you here the data. The girl was the one with the IVH, and when you have a closer look to this girl, you could diagnose a mild spastic diplegia with a gross motor function classification scale of 1, which is not severe. She had no neurosensory impairment and had an MDI at 2 years of 103, so within the normal range, and a psychodevelopmental motor score of 62. So there was a slight motor impairment, but a normal cognitive development. And after 5 years, she still had a normal cognitive outcome. The boy, with no other morbidities, with a good birth weight and a good APGAR score, did show no CP and no neurosensory impairment, but at 2 years there was an MDI of 86, which is within the lower limit, but within normal range, and also a PDA, so a psychomotor index of 73, which is below. It's a mild impairment. And after 5 years, there was a cognitive outcome score of 82. So he showed mild cognitive and motor impairment. And actually, probably that's not what we expected. And you see that there are other influences, sex, or in these infants, or probably there was a very nice family supporting the baby with the CP and the IVH. So there's more to it, just the diagnosis. So development is not always easy to predict, and many factors are influencing it. Individual trajectories are important for us to learn how it works, and also to see if our prediction models are good enough, and if really which diagnoses lead to what outcomes. But we see that this is really difficult. And we need to have longer assessment periods up to school age, or even longer, to see the full outcome of these babies. So why is it important to assess neurodevelopmental outcome, and what should be assessed? Actually, early recognition of developmental delay is important to initiate early interventions, and that would be another part, and we can discuss all this, what is possible to do. But monitoring and supervision of family and the individual developmental trajectories of these infants is important to know. We want to predict future outcome. We want to target any neuroprotective strategies, if there are some. We want to do parent counseling, and we want to know what's happening with our babies treated in our intensive care unit. So it's a kind of a quality assessment. So that's all why I think it is important to assess neurodevelopmental outcome. And I think we all assess mortality in these babies, but of course morbidities and neurodevelopmental outcome on the long run is also important and needs to be assessed to really make sure what are the problems in these infants, and how good is our management. So survival rates are improving all over the world, fortunately, especially in the extremely preterm babies. Also in my institution, Medical University of Vienna, you see we have thankfully very high survival rates in preterm babies. But of course there are medical problems. So we have to know what is happening to our babies who suffer from BPD or from NEC and from IVH. What is the outcome? Now coming back to some international data, and this is data from 2019. And you see when you look around different countries, you see different data. And this is just discharge, so survival. And this is ranging from 80 to more than 92%. So you see that it's just different in Europe countries, just looking at that. But of course, if you would look to all over the world, it would be really different. And of course, this is also reflecting in neurodevelopmental impairment. We have data from 10% to up to 26%. So there is a big variety between the countries and between different regions. And sometimes these data are quite old, because when we talk about 2-year outcome or 5-year outcome, it always reflects neonatal intensive care of many years before. And also below 23 or below 24 weeks, there are data not a lot. But quite recently, here we have a systematic review of babies above or below 28 weeks. And you see that the overall cognitive delay is around 30% in below 28 weeks. Severe is at around 10%. Overall motor delay in 45% of babies, and moderate to severe again around 10%. And cerebral palsy, which was decreasing nicely over the last years, also around 10%. So that's quite recent data from 2018, and also coming from different studies. And then it's also important how we present these data. These are data from the Epicure studies. We see also not so recent data. But if you look here to, for example, 25 weeks, you can present it at there was 30% infant died and 20% survival with disability. But actually you can also say there was 50% no disability. So it's always interesting how you present the data. And actually we can talk about, okay, there were 30% of babies dying, and in the surviving infants, there were 30% survival with disability and 71 with no disability. It's just the same data, but that we should think how we present it. Usually neurodevelopmental outcome data are given only in surviving infants. If you of course include the whole group and include also the babies who died, then you will end up with a lower number of infants without disability compared if you just present it in the surviving infants. But what is interesting for parents when you counsel them, they want to know how big is the chance that my baby is surviving, and how big is the chance if it survives that there's no disability. But of course, it's the same data, just presented in a different way. So this is also important that we know it when we compare data and when we look at it. Here data from Sweden, the EXPRESS study from also some time ago. But here you see no or mild disability in preterm babies below 28 weeks in more than 70% of babies. So it's similar data. They also presented data after 6.5 years, also in very tiny babies of 22, 23, 24 weeks. And you see that there is an increase of survival without disability over these weeks, but it's not that huge difference between 23 and 24 weeks. So probably it's a stepwise increase, but active care is influencing this much more than the gestational age alone. So the willingness to make them survive is very important. So here we have data which are from 2005, so quite some time ago, but it's a very much cited publication. Cerebral palsy around 10 to 15%, 80% survival rates, and in below 26-week-old babies, but severe cognitive impairment of 22%, moderate 24%, mild 34%. So these are quite high numbers. And actually it's a nice paper really comparing boys and girls, and you see that there is a difference, and there is a difference of each gestational week. So you see 23, 24, 25, there is a slight increase, but again between 23 and 24 is not such a big difference. And we see that it's more important, the impairment is more found in boys. So here again, data from the same group showing that there is an effect on cognitive and mathematic processing in two cohorts. It's from Germany and from the UK. And you see that over the week in gestation, these executive function is increasing increasing. So it is dependent from gestational age. So cognitive skills, reading skills, math skills, special educational needs are different if you're born preterm, and it's 10 times increased that you have special educational needs when you are born before 26 weeks. Here also as a report over the gestational age, and you see that it's quite linear, the need for special education. So how accurate can we tell what is happening with a baby later on, probably at 2 years? And you see that there are some data showing, like this paper of 2018, showing that 2/3 of infants with a low mental developmental index at 2 years had a normal intelligence at 10 years. So there's not so good correlation, and the babies are tending to get better. That's what they showed here. Here we have also data from Sweden again, where they saw that even babies who were diagnosed at 2 years as severely impaired had kind of 20% only moderate after 6 years, or up to 8 to 10% had none or mild. So there's an overall good correlation, because the ones who were normal at 2 years, also 60% of them were normal after 6 years. But still there are some showing some moderate and severe impairment later on, and the other way around. So it's after 2 or 3 years, that's not the final word is spoken. So also here, these data, for example, show that it can also be the other way around, so that infants, who had difficulties at school age were classified as having normal outcome at 1 or 2 or 3 years. So it's not so easy, and 2 or 3 years might be too early. So there are also behavioral disorders in extremely low birth weight infants. Your anxiety, autistic disorders, attention deficit syndrome is highly increased in this population. So it's not only motor and cognition, it's also behavior. So what do we know about preterm babies in adult life? So there are some growth problems, there are neuromotor problems, there's in general a good health status, but also might be some impaired respiratory function. There's lower levels of graduation and lower amount of higher education. There's an increased anxiety and depression, but mostly they have a normal social life and good quality of life, at least from the reports we know. And metabolic syndrome and cardiovascular and renal consequences, we probably don't know everything about that. So there might be also things like that we just start to notice. So this is, I think, a very interesting table showing what neonatal factors predict intelligence 26 years later. And there is most important risk factors, and there's a different impact on that. And surprisingly, intraventricular hemorrhage, of course, it's reducing intelligence, but it's not the highest or the worst thing what can happen. You see, for example, mechanical ventilation or respiratory distress is reducing, or if you have a poor parent-infant relationship. And things like parental feeding and high socioeconomic status is increasing intelligence. And you see that has a much higher impact than, for example, IVH on the other side. So socioeconomic status turns out to be one of the most important influencing factors for neurodevelopmental outcome in these infants. So when should outcome be assessed? We already tried to talk about this. So 2 or 3 years might be too early. We have to wait for school age to have a first good idea. So now we can talk about how can we assess it, so which methods can be used. And we can have, or we can use parent questionnaires. Of course, this has its disadvantages. There are screening instruments which can be completed by professionals, like the Bailey scales of infant development. I think that's probably overall the most used developmental scales. Griffiths, Denver, CAT clamps. This also can be used. We have parents' questionnaires on social and emotional focus. We have intelligence scales like the Wechsler, primary and preschool intelligence scales. We have Kaufman's assessment battery for children. We have Peabody developmental motor scales. So you see they have also a focus, a different focus on parents or social emotional focus, intelligence or motor or both. So it really depends what kind of scales or tests or questionnaires we will use. The Denver developmental scales are very easy to use because you just classify the milestones on the developmental age. Bailey scales of infant development, you have to really go through a special item series with the infants, so it's more difficult to do. The parent questionnaires, of course, are quite easy, but self-reporting or reporting by parents can, of course, be a problem, but it's available in different languages. And especially in the last year, I think, where contact with parents was reduced, this was very helpful still to have it. And there are reports that there's a quite good correlation between the Parker parent questionnaire and the Bailey scales at 24 months of age. So assessment of a healthcare professional should be preferred, of course, but there are self-reporting questionnaires or questionnaires for parents. And if there is a professional assessing neurodevelopment, it should be most optimal a developmental psychologist or someone very experienced. So what are the pitfalls? What are the difficulties in comparability of these data? We have different definitions. We already talked about that. There are different countries, different reference values or norms, and therefore we have different results. You see that there is no cross-cultural validity of standardized assessment or screening tools. So we have to be aware that data for one culture or country are not the same in some others. So we have probably to have our own norms and references for our own countries and cultural context. So here, for example, we have Bailey scales of Austrian infants with German norms. And here you have the same infants tested with US norms. And you see there are big differences in outcome after 2 years if you use different norms. And actually, these data are already published. And you see that there is a big difference at 2 years of age. And the Dutch people find very similar results comparing the US and the Dutch norms. So for Europe, it might not be suitable to use US norms. In our follow-up clinic, we use neurological examination at discharge up to 12 months, 1 or 3, depending on the clinical state of the infant. At 12 months, we have the first Bailey scale assessment and eye examination. At 24 months corrected age, we have a second Bailey scales and clinical and neurological assessment. At 3 years, we have another Bailey scale assessment and also clinical, neurological and neurosensory assessment and language testing. And at 5 years, we have a cognitive test, usually the Kaufman assessment of battery for children. And we have some parent questionnaires. So that's our own approach. So we are following our babies up to school age. And we also try to work with early intervention programs, also starting during hospital stay. But this is mainly physiotherapy. It sometimes is also occupational therapy. We have this family-centered, family-integrated care. We have parent educational programs. We have also improvements of the parent-infant interaction and some stimulating environmental issues like music therapy or reading to the babies, stuff like that. And yeah, reading, singing, massaging, music, stuff like that. Yeah, and there are some data on the intervention programs, but I think this is not so easy what is really helpful, and we have not enough data to show what is necessary at what time point for what baby. So we know that the high-risk infants would definitely benefit from such a thing, especially the ones coming from a lower socioeconomic background, because these parents probably need more support in supporting their babies. So now at the end, I will end with a comparison of data from Virgilio's hospital and from mine, because we thought, okay, let's compare our data. And here we start with the numbers. And you see, we put together data from 2009 to 2016, and we assessed a 2-year outcome with the Bailey 3. And you see in Vienna, there was sometimes also Bailey 2 used. So there's a third edition and a second edition. And this makes a difference because in the third edition, we also assess language separately. And you see that there were nearly 200 babies in this time period in Ancona and nearly 600 in Vienna. So it's different in size. Then we try to use the same criteria for the definition of neurodevelopmental disability. So we had cognitive and motor scores of the Bailey 3. We tried to assess CP separately and the gross motor function classification scales levels, the visual and the hearing impairment. And overall, we classified a composite score of mild, moderate, severe impairment and no disability. So here the data of these infants from 2009 to 2016. And you see there's a difference in mortality and also in missing data. And a quite similar range of severe impairment, but a lower number of no disability in Vienna. So of course, this is influencing. If you have a higher number of surviving infants, you end up probably with a lower number of no impaired infants. But at least the number of severe and moderate impairment is similar or not so different. And if you only look at the infants who were assessed, so we put out the died babies and the babies where no data are available, then you see that there is also some difference, especially in the mild and in the moderate impairment, and these are higher rates in Vienna. So is it really comparable? Because the bigger center need to transfer more patients. So mainly the stable infants are transferred, which is a selection bias into the more severely sick babies, which are probably the ones who are more severely impaired later on. The bigger centers gets more antenatal transfer of higher risk infants. There's again a selection bias probably here. Higher mortality should lead to lower morbidity and to lower impairment rates on the long run. And of course, we had to look at the distribution of different gestational age groups, but because we just compared below 28 weeks. But in Vienna, for example, there was 45% of babies 24-25, and this group was only 30% of the Ancona group. So you see, actually, probably the distribution of gestational age groups were not similar and not comparable. So you see, you can have an overall look and you see, yes, overall, there are 80 to 90% favorable outcome in these two centers, which is not so different, and 10 to 20% of moderate and severe impairment. And if we add, for example, data from the Sweden Express group, and if we now add data from Vienna, including 23 weeks, and even the Swedish data, including 22 weeks, you see that this is definitely influencing the outcome. So probably when you look from 24 to 27 weeks, it's about 85 to 90% of favorable outcome. If you look from 23 weeks, it's 75 to 80%. And if you look from 22, it's 70 to 75. So overall, this is good news, I think. Coming back to our own data in Vienna, here you see data from 3.5 years. So also overall, you see that in our experience, the outcome data are improving over time. And here we have the cognitive outcome at 5.6 years. And you see that the normal or mild outcome in below 28 weeks in nearly 90% of babies. So it is important to assess neurodevelopmental outcome, at least that's what I think. Neurodevelopmental outcome is very difficult to compare. Definitions of impairment are not the same. The method of assessment are not the same. There are regional differences, regional reference values or norms. The sizes of hospitals are not comparable. Mortality, morbidities are influencing, of course, long-term outcome, even if there's early intervention programs. The socioeconomic status is one of the most important factors, and we have to support especially families with low socioeconomic status. But overall, nowadays in Western Europe or in Europe, overall, below 28 weeks, there are between 75 and 90% of infants having a favorable outcome. So now I'm looking forward to any questions and looking forward to the discussion. Thank you for your attention.
Can I start with a question?
Yes, I cannot start my video now, but I can hear you.
Okay, thank you. Could you comment a little about the influence of brothers and sisters on long-term follow-up of the former preemies?
Sorry, I didn't get the question.
The influence of having brothers or sisters older than you, so to grow in the same house with peers, with the other children.
Yeah, very interesting question. I always ask about data, but I'm not aware that there is data, especially looking on this aspect. But maybe anyone else knows.
There is, may I intervene? Virgilio, you hear me?
Yes.
Yes, yes, yes.
There is also another interesting things. We look at firstborn and secondborn, and we have like a series of 1,600 babies below 32 weeks. And incredible enough, there is a difference in their development at 2 years in the second pregnancies. It is a bit unexpected. We're going to publish this. I don't know how interesting it is, but it's second babies with the relatively good statistics are larger in size, but they are shorter of 2-3 points, which it's totally below 32 weeks, whether you would expect. So I think there are still things we don't fully understand. Well, it's well known in human term pregnancy. The second pregnancy, babies born to second and subsequent pregnancy perform somewhat less well. But that's also another variable which I feel, commenting. I mean, so and we are checking on siblings, so older, yeah, that's also, it's a bit of an issue. Although in Italy, it's a very difficult thing these days because there's hardly any baby being born, and most of the family have a single child these days. So it's really, the sample size would be critically low. But for baby less than 32 weeks, where we do our research or we collect our data. Yeah, it's not so frequent.
I have another question in the chat. Does occupational therapy in the NICU add any benefits to the outcome of the preterm baby with mild risk factors? So actually, again, I don't know any data looking especially on that. And we usually do occupational therapy only in babies who have a prolonged stay on the unit or have more than just mild risk factors. So actually, we don't know. Even for physiotherapy, we have no really strong data. Everyone feels that it helps these babies, but there's no really hard data showing it. So if anybody have really done some studies on that, I would be really happy to see them. But these are things people are doing and not really assessing in studies, unfortunately, or fortunately, because every baby gets as much as support as possible.
Yeah, the same for us. I mean, the general feel, the general perception, it helps, but it's not done in a controlled way. I mean, in a controlled fashion. So.
And everyone has the feeling. I think it's not the therapy itself. Probably it's the education of the parents to how to handle the babies. So actually, it's more parental
Absolutely.
education than the therapy itself. So you will not defer these items really. So I think these studies are really difficult to do.
Katrin, do you use general movements in your units to assess the babies for predicting cerebral palsy?
We did for quite some while, as it was much more difficult than now to do some videos, but we stopped due to too many babies. So unfortunately, but we had good experiences. And I think it's especially in the first 3 months. So at the 3 months follow-up clinic, now we try to assess it, and it has a quite good correlation to the CP incidence. So yes, it's a nice and easy to do thing.
Yeah, we're certainly using it a lot in our neonatal units in Australia and in follow-up.
Because when you do it too early, you see a lot of poor repertoire babies. So actually around term age, it starts to be nice. So I think from 36 weeks onwards, I would like to do it. Before, it's a lot of work and not so helpful probably. But what are your experiences?
I think if you're finding cramps synchronized, then that's quite concerning. But certainly we see a lot of the poor repertoire, and at 3 months of age, it's much more predictive.
So fidgety yes or fidgety no, that's really the point you need to see.
Yeah.
We do
and
3
then,
months. Sorry, go ahead.
I was going to say, and then babies who have absent fidgety are linked in with the Cerebral Palsy Alliance early on, so for early intervention.
Yeah, but my experience was it was never really surprising which babies had no fidgety. So actually you had these babies also on the high risk track already, I think. So it was never really surprising.
The usefulness depends a little bit on your rate of cerebral palsy. And these days, cerebral palsy is becoming more and more rare. So you really have a decent tool to predict cerebral palsy, but cerebral palsy is a rare event. So it's sort of, and you can pick up other things probably. I can show you, I don't know if I put the general movement data on it, but it's something we are doing. I think they are highly predictive, or in good hands, they are predictive, but the outcome is rare. I mean, the negative outcome, fortunately, is rare these days.
Yeah, it's good.
Yeah, Katrin, I'm sorry, your microphone is switched off.
One comment, Katrin, that you said that you pointed out concerning the Ancona. I will present some new data from Ancona, and of course we will exchange the data. But distribution, even in a relatively narrow gestational age segment, I mean, this distribution of the baby can be of importance. So we should do some correction, some regression also by gestational age or by whatsoever parameter. I would be curious why. Do you have like a bias for referral at low gestational age? Because I would expect your center to get all the baby less than 28 weeks, right?
No, we are not capable of doing all. That's the problem. So we really select the below 26. So we have.
Oh, I see. That's why you have an excess of baby or more than 26. Yeah.
If you just look to the whole group, it's just overrepresentation of the very young ones. Yeah, but it's interesting to see how these data are really need to be looked into more detail, because you cannot just put them aside and say that's the same.
I will show some data by each gestational age if there is time. I brought some data to discuss, and we can see the effect of gestational age on that.
Yes, it would be great. So, but actually, I think if there's no more questions, it's your turn, Virgilio.
Okay, shall I start?
Yeah.
I do sharing. Please let me know whether you see what I'm doing, what I'm presenting.
We see what you do and what you present.
You see the slides? The colorful slides?
Yes.
Excellent.
We missed the green for Italy.
Okay, so some things were said already or commented. I go a bit fast on that. So it's a nice opportunity. I'm happy to, to discuss some of the data with you and perhaps stimulate some interesting discussion. These are some of the points. Extremely low gestational infant these days have very high survival rate. Neurodevelopment outcomes are extremely variable. Normally the best center publish the data, but we still have a lot of variability. And some of the variability comes because of bad standardization on outcomes. I brought some data from our center for the sake of comparing with Katrin and stimulate discussion. Risk factors affecting brain may also vary from center to center. And if there's a bit of time, I would try to describe what we are doing to understand association or risk factor in order to mitigate some of this risk factor. Neuroprotection, neuroregeneration is out of the picture for today. So survival, that was 95, Europe, 2005, 2007, much higher percentages, survival percentage, 23, 24, 25. This is the Ancona data, and is from 2019 and 20, so very recent data. As you can see, 25 really reach 100%, 24 more than 80%, and 23 we leave a lot of sort of the parents really to decide, so we are not really that keen at this very moment on the 23 week. This is explained, but anyway, the bottom line is that we are these days at 25 weeks nearly 100%, and at 24 more than 80%. So survival is really getting better. Also, please note that in our region, with 1.5 million inhabitants and 10 to 15,000 births, depending on the year, because I told you there are dramatic changes these days, neonatal death, early death, are 1.6, 1.5 per 1,000 births. So again, same message, deaths are very rare these days. And the problem with this extremely good survival rate is sort of illustrated in these papers from the Dutch. They did a meta-regression. They took 7-1 studies on preterm, 7,000 baby, less than 32 weeks, 5,000 term controls. And what they show, these are all the studies, the 0 is the identity line. Let me see if I can get the pointer. Yeah, is the identity line here. And all premature baby fell short of about 1 standard deviation, half a standard deviation in cognition. On a greater magnification, you see you're missing 1/3 of a standard deviation compared to term baby. And this is probably an area where we should invest and try to mitigate this problem. Is the situation getting better? No, I'm afraid. If you plot this data over time, you see that probably because of the increased survival of the extremely low gestational age infants, the difference from the mean is not getting better. Actually, well, probably is not statistically different, but is certainly not getting better, is the same. So no improvement in cognition from over this study period. So the real issue is that we don't yet know, or we have molecules and where we hypothesize they are damaging to the brain, but little information is really available. And this different injury may be different in different location, in different unit, according to different practices. So, of course, we are interested in our Ancona data, and we start in 2004. We collected all data, diagnosis, severity score prospectively in all baby less than 32 weeks. and we have now 1,600 as we speak now, and we have more than 800 Baileys on this baby. And our major interest is to sort out whether growth, nutrition, disease, what are the major determinants of this loss in or this neurodevelopmental outcome, which is inferior to term babies. Today, I will show you some data from on neurology. Of course, we have similar data on growth, on lung growth, kidney and endothelium. And these are the major diagnoses we use, and they were defined 2004 and prospectively assigned to the patient. And we have anthropometric prenatal data, and several risk factors are available. Well, next to this sort of clinical data, we obtain near-infrared spectroscopy in 250 babies, ultrasound in 5,000, EEG in 400, NMR in 415, general movements in 590 babies, and Bailey is available now in 833 infants, and I will mention briefly. But before really we get in this association of these things, I like to show what are the data, our outcome data in baby 24 to 31. I really wonder at this point, now I regret I brought this data, because probably the most interesting part will be 24 to 27 and 6 days. But I'll go fast and see and just comment the major points. This data you show already, you have seen it already by Katrin, and to me is the most important slides of my talk. And please, let's share a common definition for neurodevelopmental disability. Bailey 3 is the tool that many of us are using, but you also have the CP, GMFCS level for motor, visual and hearing impairment. So this is what we are using. This is what we somewhat agree to share with Katrin. Please don't hesitate to ask, and if possible, try to comply with this scoring system. Otherwise, the data will be very different, will be difficult to compare whether baby are really different or our scoring system is different. So for 2009, we have 874 babies, 756 are available. These are the inclusion criteria, which I'm sure you're not interested in. And we have 818 babies, 203-day gestation, 1,100 grams. And if you look at the death, which is 6%, 8%, 7.5%, there is some missing data. And this is severe, moderate, mild, and no disability. Of course, deaths are there. They can be variable. And we are not very happy with this missing data. The only thing we could do with the missing data, we do some statistics, and we make sure that these missing patients did not differ for the major neonatal demographic and clinical characteristics. So we sort of can be rather sure that the baby that came a follow-up are representative of the whole population. This is a better graph. I mean, it's easier to understand. And if you take this baby up to 32 weeks, severe impairment is 1.3%, moderate impairment is 3.7%, and if we put together mild and no disability, we go to 95% normal or mildly impaired. Same data on numbers, and you can see that we get 95% no disability and mild impairment, which I think is a very reassuring. We are very happy, let's say, pleased with this data. That wasn't the case 10 or 15 years ago. 15 years ago, I would say. Well, one interesting point for discussion, please note that we do not find a marked difference according to gestational age 24 to 25, 26, 27, 28, 29, 30, 31. So there are differences, but they are not that significant. We don't find that gestational age plays a significant role in outcome. What is significant, what is biologically significant, what is statistically significant, we can discuss if you like. But this is cognition. On motor, actually, our motor disability seems to concentrate more on 26 to 29, and we don't have that many 24, 25. Again, without a marked significant effect from gestational age. And these are the number. If you rather memorize the number, which are available to you, of course, instead of looking at the graph. If we lump together the low Bailey and the neurosensory impairment, again, you see this is sort of the overall neurodevelopmental disabilities, 24 to 31. You see there is no marked effect of a gestational age. And these are the numbers with a very small number in the moderate and severe impairment. So if you take the Bailey for cognition and motor, overall, this population is rather okay. Average value is 94, plus minus 14. Let's say, suppose we take 100 as a reference. We are 6 points below the 100. Standard deviation is 14. So we are short of half of a standard deviation, which isn't bad in our opinion. And motor is 100 plus minus 13. If you look at the cerebral palsy, 3%, only 17 cases. Visual impairment, only mild, no moderate severe. Hearing impairment, 0.3 and 0.2 without severe. Okay, so we can discuss that this is too large a population, too large a sort of gestational age segment. So let's look at 24, 27, which is more relevant to what Katrin presented. Here we have fewer patients, 195 completed the 2-month follow-up. These are the exclusion criteria available to you if you like to look at it. Gestational age 184 days, birth weight, mean birth weight 811 grams. I skipped the mortality, but is available. And again, we have 2% severe impairment, 6% moderate, 18% mild, and 73% no disability. These are the numbers, 2, 6, 18, and 73%. So let's say 8% severe moderate disability and 92% no disability of mind impairment, which is something I never thought about 15 years ago. So we would have achieved in our unit. Again, please note, cognitive, 157 patients, no marked effect of gestational age. You see visually, you don't see a disaster at 24 and 25. So please have a look. This is the figures for cognitive. These are the numbers. And the motor, again, it seems like the motor problem are more problem. I mean, no statistical difference at 26, 27, but no major motor problem at 24, 25, 157 babies, not that many, unfortunately, or fortunately, I would say. And again, Bailey in this 24 to 28, 27, 6 is 92 plus minus 15. So we are short of 8 points. So only half a standard deviation below the 100 mark point. Motor is somewhat less, 98 versus 100 with a standard deviation of 14. If you look at disabilities altogether, cerebral palsy 6%, visual impairment only mild, hearing only mild, and 1 severe, 1 case. So this is the number as they are now, let's say. Can we learn something from near-infrared spectroscopy, ultrasound, EEG? Of course, I will not have no time to look into all these because they are all separate studies, and we have now the combination of different technique for the prediction of outcome. I would like to report to you 4 or 5 messages. Is brain near-infrared spectroscopy useful? We have a bit of experience. We started only 4 years ago, 5 years ago, I don't remember exactly. And in 129 preterm infants. And this is our univariate analysis for cognitive, motor, and language. And these are the significant predictor at the univariate analysis associated with cognitive score, motor score, and language. Forget for the moment late onset sepsis, intracranial hemorrhage, BPD, asphyxia, PVL, and so forth. Please look at the near-infrared spectroscopy with value less than 55 for either more than 6 hours or more than 10 hours during the first 72-hour life. We found a correlation with cognitive, and we found both correlate with languages at 2 years. These are the graph. Big variation, as you can see. These are hours of near-infrared spectroscopy less than 55, and this is cognition at 2 years. This is the motor, also significant. It's all, you know, we have these thick cases probably with the leverage effect contribute to the motor effect. But if you look at the language, the effect is quite important. We did, of course, the inverse correlation between hours of near-infrared spectroscopy less than 55 and language at 2 years. Of course, we did multiple regressions. We included more variables. As you can see here, hours of near-infrared spectroscopy less than 55 is significantly associated with the cognition and is highly significant associated with language, taking care of other variables. It's not a randomized study. We don't have yet randomized studies, but we are kind of in favor, and we trust this association, and perhaps we can discuss more in the discussion session. We are also into brain metrics, brain volume measurements, and we find that the cerebral cerebellum size is very important in this baby, and we are after. Why? So we have a series of more than 200 NMRs, 450 altogether, but you know, the clean one, the good one, are close to 100. We did all kind of linear measurement in the brain. And something I like to stress with you, and probably that I believe it's important, is that we decided a couple of years ago to divide the babies in baby without brain injury and baby with brain injury. Because I think this is an important issue, because if you're interested in the effect of nutrition on sepsis, and you want to see whether nutrition or sepsis or other, like say, medical risk factor affect neurodevelopment, and you do include your baby with significant brain injury, you may find a noise that prevents you to seeing the effect. So we chose this approach, and therefore these days we try to do regression or statistical study in the whole population, but as soon as we can, we sort out the predictor of babies with brain injury, of neurodevelopment, of baby with brain injury and without brain injury. What is the definition of brain injury? Brain injury is abnormal ultrasound at any time during the first 3 weeks of life. So we have 230 baby that got NMR, 193 had the NMR of good enough quality. What we found as you would expect, that I don't have time to comment all the linear measurement of the brain, but please concentrate on transverse cerebellar diameter, which in no brain injury is 52 millimeter, and in brain injury 50. Well, no surprise, because of brain injury is affecting also cerebellar health and growth. And you can see here that the cerebellar diameter was lower in brain injury as compared to, this is a hot topic, and there are also very interesting data on basal ganglia we have in this line of thinking also. Anyway, the interesting part was that at 24 months, motor was, of course, statistically significant between non-brain injury and brain injury. And cerebellar diameter, you see, was associated, was correlated with cognition at 2 years. With at the univariate and also at the multivariate analysis. And this is the PL for the cerebellar diameter. What we did, we were able to separate out baby with no brain injury and brain injury. And to our surprise, cerebellar diameter size or transverse diameter was correlated to cognition in both brain injury and non-brain injury baby. And this persisted after the correction for gestational age, gender, maternal education, and postmenstrual age. So there is, we think is a quite solid finding. For motor, the same story, correlation with motor in both brain injury and non-brain injury, and after the adjustment for the common confounder or common association with motor development. So in conclusion, reduced cerebellar at term equivalent age, diameter term equivalent age, correlated with cognitive and psychomotor score, and this was true in both brain injury and both non-brain injury. Of course, we do additional tests, and we have several regression, and I don't want to bother you with that are predictive, or actually, that are meant to study the association with the risk factor and cognition at 2 years. As you would expect, you have gestational age, SGA, maternal education. We find them all. But one critical point, please note, is that if you put the disease, the condition, BPD, PVL, you will find, of course, that the prevalent condition affecting cognition are the disease. But the interesting approach we took 2 years ago is we do in baby without the condition, in baby without major brain lesion. And there we are in a better position to understand the role of nutrition and the sickness or medical illness is not associated with intracranial lesion. And this is, again, a model of prediction for the motor at 2 years with several parameters, which I'm sure you're already familiar with for motor, like gestational SGA, maternal education, IVH, BPD, PVL, and so forth. One last, I have a few more slides just to tell you that clinical severity beyond diagnosis is something we should consider in our babies. So we have a score for sickness and for feeding intolerance, because we are a group interested in nutrition, and we incorporate this into our prediction models. And we found that these situations of interest. We played in several ways to separate less critically ill newborn and more critically ill beyond diagnosis. So we are beyond diagnosis at this moment. And interesting enough, we found some interesting surprises. If you compare the role of nutrition in less critically ill infants, and this is a case control study, well-matched control groups, you find that the infant who got insufficient nutrition, less than 20%, 50% than the target nutrition, versus the infant who got adequate nutrition, there's no difference in body size at 2 years, nor difference whatsoever in cognition. 94 versus 93, 102 versus 99. So if you do match for severity, for clinical severity, and you correct for diagnosis, or you rule out the major diagnosis, neurodevelopment in our Ancona's data is not affected by suboptimal nutrition as defined by less than 50% of our target value. Of course, I cannot comment whether in other center this baby would have received 50% less of the target value. So this this is a very local data. So if you compare more critically ill infants with a higher score, and again you compare baby that got nutrition on target and baby that got nutrition 50% below target, is not minus 50%, is 15, 5. Again, no difference in body size at 2 years and no difference in neurodevelopment. So that's, to us, is kind of important. Please note, of course, that the cognitive here is 90 versus 90, motor 93 versus 93 in more critically ill infants. Let me go back one. If we go in less critically ill, you get 94, 93, 102, 99. And this difference is highly significant between less critically ill and more critically ill infants. So I like to close by challenging a little bit the notion that in-hospital growth and nutrition affects neurodevelopment. These are data from the US. In 600 baby, 501, 1,000 grams. We did the same, of course, with fewer infant, 284. And please note that the cognitive in the US cohort, it's already 2 decades old cohort, was associated with hospital growth. In Ancona, this is not the case. Motor inverse relationship in this published network in the US, no effect in our cohort. Cerebral palsy, significant effect, no effect whatsoever in the Ancona cohort. Neurodevelopment impairment, correlation, no correlation in our patient with a smaller number. So I think we made a bit of an effort to correct for sickness, for diseases, as probably nutrition or suboptimal nutrition does correlate with level of sickness. So I come to an end because I promised I would have been short. So I try to sort of tell something you knew, that Elgans have a very high survival rate these days. Neurodevelopment outcomes are very variable from center to center. Unless we standardize outcome, we won't understand much of the association and of the risk factors. I really would like, as we enthusiastically started talking with Katrin, we go further in comparing outcome, perhaps level of sickness. And let's be aware that different clinical practices, different obstetric practices, different referral from our hospital may vary tremendously from center to center, and they can act as very important confounder. I show you some attempt we are doing to correlate clinical severity with major diagnosis, clinical illness and severity, and outcome. And I'd like to thank our team of the Marke Neonatal Network and our follow-up team that did a job, and over the last year collected for us is very precious material that allows to better understand what's happening and develop possibly mitigation strategy to reduce this neurodevelopmental outcome. Thank you.
Yes, thank you. And we are really only 5 minutes over time. That's great. And I don't see any questions in the chat, but probably they are coming. So let's see. There was supposed to be a 10-minute break now, but we decided, as we have to fit in one of the case reports who was left over from yesterday, we would like to go on if it's okay for everybody. But Ram, you wanted to say something?
Yeah. Any comments about, we tend to think in silos. We have some experts in neurocritical care, some neonatal hemodynamics, neck societies, and we don't tend to connect, for example, gut, lung, brain axis. What happens in the gut, impacts lung. What happens in the lung impacts brain. Dr. Virgilio, any comments on how do we put them together and treat the baby as a unit, not partition, and focus only on one part of the body of the baby?
Thank you it's a very nice question. Well, there are some common sort of congenital consideration, let's say. For instance, SGA baby have a poor neurodevelopment, poor vascular growth, poor gut blood flow, poor smaller lungs, more BPD, and it's very tempting to think that BPD is because of bad nutrition. But in turn, you could look at BPD is part of the lung apoplasia associated with being small gestational age, that, by the way, they grow poorly. So there is some congenital, let's say, or linked issue, probably because of genetics or because of intrauterine environment that brings together these associations. Then you have the inflammatory syndrome, which often that may occur prenatally and postnatally. And we have some interesting data. For instance, you will love this data. We took I will be short. We took the baby that developed once. We are measuring the oxygen diffusion to the lungs. This is a lung talk on lung growth and development. And we're measuring, like Jane Pillow, sub-atmospheric air depleted with, diluted with nitrogen. So we let the baby breathe, like 18, 17% oxygen. By doing so, we are able really to assess oxygen diffusion in the lungs. It's unbelievable. Baby that got sepsis, at the time the sepsis were identical to a control group. 1 month after sepsis, we can measure the lung growth was affected by sepsis, even without ventilation, just by a systemic inflammatory syndrome. So I have no hesitation to believe the same growth impairment that occurs at any age in pediatrics with sepsis, with inflammation. If you have like a rheumatoid arthritis, you don't grow that well. If you have a chronic inflammation, you don't grow. And now this is becoming more and more apparent in our cohort. We see smaller diffusion in the lungs 1 month after sepsis, and also poor cognition. So it's what you sort of, your question, your comment is extremely appropriate. And this is actually one of the area where I would like to invest in the coming years, because it's, and we know still rather little on the propensity, I don't know what is the right English word, on the susceptibility to elicit a strong inflammatory reaction for a given stimulus, for a standardized stimulus. So look at what happened with COVID. COVID, we have individuals that develop a terrible syndrome and individuals that are totally resistant really to COVID infection. My mother was 92, 93. She got COVID. She had nothing. And she had fever for like a week, like 40 degrees. And now she's stronger than ever. She's 93. And I have some colleague or some people I know, they're age 40, they got white lungs. And it's not only viral load. I'm sure there is some, the defense mechanism, but they also some different reaction to a different inflammatory pathway or different degree of inflammation associated with a given injury. And this is really a wonderful area for investigation in neonatology. Thank you, Ram. Nice question.
Appeared something in the chat, but it's already disappeared. So
okay.
So probably we continue with the case.
Yeah.
Hello, dear colleagues. I would like to make a presentation of a clinical case that we had in the West Kazakhstani area, to be more precise, in the Regional Perinatal Center on the 11th of August 2019. Diagnosis is congenital bilateral choanaatresia. Here comes the brief case history. The diagnosis, I said, it's congenital bilateral choanaatresia, and the clinical presentation is it's a female child born 3,710 grams, length of body 54 centimeters, 7-8 ABGA score at the tertiary center after birth. The situation deteriorated, cyanosis, difficulties breathing. To the neonatal unit to clarify the diagnosis. The results of investigation: CT, that is the 3rd day of life, that the nasal passages are really narrow and choanas are filled with muscular substrate more to the right, and on the left there is a partial patency. So otolaryngologist checked the case and diagnosed bilateral choanaatresia, and endoscopic treatment was recommended, so this for the prophylaxis of following restenosis. The result was the elimination of atresia and free nasal breathing. Here goes the relevant history and presentation. This is first pregnancy, first term delivery, weight 3,710, body length 54 centimeters, the head circumference 36 centimeters, and chest 37 centimeters, ABGA 7-8. After birth, the neonate has difficulty breathing. Any attempt putting the child on a breath, the child gets cyanotic, nasogastral tube, which was a diagnostic method, and that was impeded on both sides. It could not be done, and the consultation with otolaryngologist was done. After the number of tests, the preliminary diagnosis was the bilateral choanaatresia. What was recommended was a CT with nasopharyngeal area and also the mouth and the skull, so partial atresia of choanas. And I want to give to your attention, I want to draw your attention a video of the child after birth, and then to show you that there are difficulties breathing. Here you can see that lying down, and when the mouth is shut and he can't do the inspiration, so he tries to open the mouth and then he goes through the mouth and can't breathe through the nose, so the child starts being really anxious and starts crying, agitated. And this baby on the 3rd day of life, when the diagnosis was made, the CT, we transferred to the surgical treatment, endoscopic treatment, and that is the operation at the procedure as it was performed. And then the baby had a thin catheter put in to prevent the restenosis, and that would remain in place for about 40 days, and then 40 days later the baby came to see the doctor, and this is the baby breathes easily and the mouth is closed. Have a look, please pay attention here. And here you see the results of examination, the general blood panel. It was not a bad test, and biochemistry also, on the pH was okay. The acid and base, the X-ray of abdomen and chest was no pathology. So we never thought that there could be nothing other than these atresia that we thought. And as I said before, they were really narrow nasal passages, and otolaryngologist consultation was a bilateral atresia that was wonderfully eliminated. Our otolaryngological surgeon, he's done it, and then neonatologist consulted. The prophylaxis of restenosis was done, and today this baby is 2 years of age. What kinds of interventions and treatment were done? So there was antibacterial treatment that was starting with ampicillin and gentamicin, and endoscopic surgery that was hydroseparation of mitochondria, and restenosis prevention. And post-op period there was lavage of nasal passages, and the catheter was there for about 40 days, and the child was in a post-op, was in a care unit, and he was the prescribed expected amount, and since it was inconvenient, putting him on a breast was difficult, but he was fed through the bottle, and after the catheter was removed on a day 40 without any difficulties, the child was on the breast and was on mother's milk. What went well? Good teamwork, that is doctors, nurses, parents, the hospital and other organizations, they helped a positive, really good outcome for the family. Regionalization of perinatal care, that was timely transfer to the organization where the specialized care was provided. Examination following the rare disease, consulting of the specialist, that is otolaryngologist, and the Scientific Center of Mother and Child of the Republic of Kazakhstan. The correct understanding and acceptance of the child disease by the parents. What could have been done better? Early diagnosis, early differential diagnosis. Although after the delivery room, the baby was transferred, and the neonatologist at this stage 4 was established. So earlier consultation of specialists. So it was on the 3rd day of life. He could have been transferred. The baby could have been transferred sooner. The surgical treatment could have been done better, and the stenting of choanus could have been done with the different catheters, more kind of gentler catheters. But this case was very rare for the first time, so of course we didn't have the necessary catheter in order to avoid restenosis, and then making sure there are no other congenital disorders. What could have been done differently? What could be done differently next time? Earlier consultation of specialists, early diagnosis, early differential diagnosis, the surgical correction, how it could have been done. It could have been done sooner. The support and help to the family, and excluding other congenital disorders. Since we did what we've done correct, making a diagnosis, was the diagnosis correct? This is what could be discussed. So how correctly we treated this, what you could advise on making our practice better. Early rehabilitation in specialist medical organizations. As I said, we work in close contact with and consult with this family, and we see this girl. We are so happy for this family that everything went well, that this child had no stenosis, no restenosis, and this girl now is developing rather well. She is not behind other children, she is not lagging behind, so we did well without hypoxia, cerebral hypoxia, so the neurodevelopmental outcome is good. That's all I've got. Thank you very much for your attention, and I wish you all good luck in your work.
Yeah, so thank you.
Well, thank you.
Or did the baby have any other malformations, or an eye exam was done to rule out coloboma because choanal atresia is often associated with it, or was the mom hypothyroid or was taking any medications, which was not mentioned. That's all the questions I had.
On the same line, I have questions concerning if there is a follow-up in terms of if this baby has been enrolled in some kind of checking after the surgery, after this intervention, whether has been follow up for being a normal baby otherwise, in the same line what Ram says.
So is the presenter with us? I see her, I think, name. Can you switch on your camera, please, or at least the microphone? Yeah, but probably while we do that, we can go on with the next case. And we can do discussions in the chat, I think.
Good afternoon. My name is Ligia Blaga from Romania, and I will present you a case of complex hepatic arteriovenous malformation with its diagnostic pitfalls. Our diagnostic was hepatic complex arteriovenous malformation, localized intravascular coagulation and thrombocytopenia, microangiopathic anemia, liver failure. We present a male newborn, 36 weeks gestational age, with birth weight 2.500 grams and Apgar score 9. He was born by cesarean section for the progression of a fetal ascites, which was diagnosed as 34 weeks of gestation. The newborn developed jaundice, hemolytic anemia, thrombocytopenia, and liver failure soon after birth. Complex hematological, serological, and imaging investigation were carried out. Imaging investigation, ultrasound, and angio-CT established the diagnosis of a complex arteriovenous malformation involving the hepatic vein and artery, the portal and umbilical vein. Aggressive treatment of thrombocytopenia, coagulation disorders, and hyperammonemia was required. Finally, the newborn was transferred to a hepatobiliary service in Geneva after 1 month of life. What do we know about history of the newborn? Pregnancy was obtained by in vitro fertilization with a physiological evolution till the 34th weeks of gestation, when fetal ascites was diagnosed. Mother, Gesta 3, Para 1, 35 years old, known with thrombophilia. She was under treatment with Clexane during pregnancy. The first clinical exam of the newborn revealed a mild respiratory distress, but he was cardiac and hemodynamically balanced, and huge abdominal distension. Respiratory distress remitted after 48 hours of oxygenotherapy. The oxygen needing was 35%. He also needed thermic support. The evolution in the first week of life was marked by jaundice with early onset in the first 6 hours after birth, firstly with an indirect bilirubin. In that moment, the total bilirubin was 5.2 milligram. Then mixed bilirubinemia was present with rapid progression. The newborn present also anemia with low level of hemoglobin, 13 grams per deciliter, and hematocrit, 38%. Also, he present recurrent thrombocytopenia. The platelet level were in the first day of life 9,000 per millimeter. The newborn need repeated platelet administration. Also, he present acquired coagulopathy, high values of prothrombin time and partial time of thromboplastin. The levels get close to the normal value after 2 fresh frozen plasma administration. We have also low level of fibrinogen and liver failure with progressive increase of ammonia from 60 to 111 micromole, and hypoproteinemia with hypoalbuminemia were present. Ultrasound imaging evaluation revealed in the hepatic hilum a vascular tangle with multiple fistula between portal vein, hepatic artery and its branches, suprahepatic cleft vein and umbilical vein. We also see an avascular area at the upper pole of the right kidney. We think in that moment that this may be a local infarction due to a microthrombus in the renal circulation. Angiosity was performed and it confirmed the presence of a vascular communication. Differential diagnosis was made antenatal for fetal ascites with trisomy 21, 13, 18 and Turner syndrome, but NIFTY test was negative. Parvovirus infection test, but the serology was negative. After birth, the first thought was to an RH or ABO isoimmunization due to early onset of the jaundice and hemolytic anemia, but direct and indirect Coombs tests were negative. We also excluded a perinatal bacterial infection, white blood cells, CRP, procalcitonin, and blood culture were negative, and also a viral infection, but serological tests for Torch syndrome were also negative. We have to exclude metabolic disorders which evolve with liver failure, such as galactosemia, aminoacidopathy, cystic fibrosis, or tyrosinemia, but metabolic screening for this disease was negative. We saw to an alpha-1 antitrypsin deficiency, but alpha-1 antitrypsin was at normal value. We saw also to a hemochromatosis, but ferritin and serum iron were at normal levels, and fetal IRM was without abnormalities. We excluded also cardiac and pulmonary malformation. Our treatment in that moment consists of albumin administration for correction of hypoalbuminemia, IV immune globulin when we saw to an RH isoimmunization, arginine for the correction of hyperammonia, ursodeoxycholic acid, and blood products. The newborn need 3 administration of fresh frozen plasma, 10 administration of platelet, and 4 administration of red blood cell. In the 21st day of life, after the first spontaneous involution of the ascites, it reappears and has a progressive growing. In the same time, the newborn develops a septic episode. He developed a sepsis with epidermidis staphylococcus, so we start the treatment with vancomycin. After this treatment, the newborn had a good evolution. After 24 hours from the beginning of the treatment, patient was without fever, and after 48 hours, CRP values was decreasing. An abdominal CT was performing again. We discovered the closure of the communication between hepatic artery and portal vein, and there is no blood flow in the suprahepatic vein. We saw in that moment that maybe it's a Bucharest syndrome, maybe due to the sepsis. The newborn had a bad evolution with of the liver failure and coagulation disorders. So he was transferred to Switzerland, Geneva, into the hepatobiliary surgery service. We sought now for the embolization of arteriovenous fistula, because in our pediatric services we don't perform this technique. But here, after 2 months, they perform liver transplantation, and histopathological exam revealed a liver structural abnormality, which was the cause of circulatory abnormalities. It was a juvenile xanthogranulomatosis. What went well in our cases? First, undulating evolution with improvement of thrombocytopenia, good management of the coagulation disorder in order to control the bleeding incidence, rapidly good response to the treatment of the septic episode without further alteration of organ dysfunction, keeping the hyperammonemia under control, and involvement of the authorities in order to prepare the documentation for the newborn transfer to a specialized service abroad. And of course, land transport by ambulance over a long distance without events. What could we have done better? Maybe avoiding the septic episode that could have amplified the coagulation disorder and liver failure. What would we do differently next time to take in consideration a possible hepatic structural abnormality as the cause of vascular malformation, and to pay more attention to ultrasound changes of the renal parenchyma, because the avascular area was actually a kidney disease baseline determination. Thank you very much.
Yeah, thank you very much. So again, I cannot start my video, but yeah, congratulations to this case. I think you managed pretty well. Yeah, any comments?
Were there any other great case, any other cutaneous manifestations like hemangiomas on the skin or on the leg? Sometimes they are associated with the hepatic ABM.
Hello. No, the newborn doesn't have any other hemangioma on his skin, and we don't find any other hemangioma into the parenchyma, neither cerebral or with other localized.
So no teleangiectasia and things like that?
No, we think to hemorrhagic telangiectasia, but we don't have any other signs to support this. But now, yes, if we think that the real arteriovenous malformation are very rare, and most of time they are due to a structural abnormality of the liver, maybe we have to saw to this abnormalities.
And did you give fresh frozen plasma and thrombocytes, if I got it right? Because I think the coagulation could have really be a problem earlier in the case, because
yes,
I think too much, it can be even worse.
Yes, but his platelet level was very, he's rise up and then he's go down. We are afraid about hemorrhagic events, because the upper level of thrombocyte we can achieve, it was 60,000 for millimeters. And so we think like this in that moment.
Yeah, I think it's really difficult to hold the balance here. There's another question. Did you consider propranolol therapy?
No.
For hemangioma? Yeah. No?
No, no.
Any other one would do that?
not such a big hepatic AVM malformation, cutaneous hemangiomas or small near the orbit. People have recommended or used it. I'm not sure if they will use it to involute a big liver AVM malformation, not even just a straight hemangioma.
And there was some idea about the antibiotic treatment in the baby, but I haven't got the question.
Not in this one, I think the previous case.
Oh, okay. Yeah, because
it
I
was a
didn't
question about the previous case.
Okay.
That the baby received ampicillin and gentamicin. So it was a question about the previous case, I think.
Okay. Okay. Yeah, so congratulations that that it turned out healthy at the end, although you needed to do a transplantation.
Thank you.
Okay, if there are not any more comments, let's check. We could go to the last case. What do you think?
Yes.
Okay.
Hello, my name is Andra Purnuța. I am a neonatal doctor at Philanthropia Clinical Hospital, and in the following minutes, I will present you one of our most challenging cases. The baby was a 27-weeker female born by emergency C-section for maternal reasons, suspected HELLP syndrome, that required a complex multidisciplinary therapeutic approach with life-threatening conditions and, apart from her prematurity, an illness with unknown etiology. She was transferred at 3 months of age to a pediatric facility with anemia and hepatic cytolysis for continuation of care. It was mom's first pregnancy, monitored in the UK, all serologies negative, uneventful until her 24-week scan when fetal ascites was discovered, and she was referred to the maternal-fetal medicine department. It is worth mentioning that she had a scan at 20 weeks, which was normal. Upon admission at 26 weeks, the baby had severe anemia, ascites, and was showing signs of cardiac failure, so an intrauterine transfusion was performed. Because mom's condition started to deteriorate, with worsening hepatic and renal function, thrombocytopenia, and anemia, it was decided to deliver baby as quickly as possible, although her survival chances were slim. The baby was delivered at 27 weeks and 5 days via emergency C-section, breech presentation, birth weight 1100 grams, and the placenta weight was over 2000 grams, which was a major red flag. She was born in very poor condition, cyanotic with petechia and generalized edema, a tuberous right lateral cervical hemangioma, no respiratory effort, heart rate around 100 BPMs with a grade 2-3 out of 6 systolic murmur, a large distended abdomen, important hepatosplenomegaly, liver with lower margin down to the right iliac region, and spleen 3 centimeters below costal margin, with poor muscle tone and reactivity. She was immediately intubated and ventilated and admitted to the NICU. The first days of life were very touch and go because she had prematurity-related consequences and also her unknown etiology pathology. She required mechanical ventilation, multiple doses of surfactant, including a bronchoalveolar lavage for a pulmonary hemorrhage episode. She had cardiac failure and hypotension with inotrope and vasopressor treatment, neonatal anemia and severe early hyperbilirubinemia that required exchange transfusion and additional multiple blood transfusions. Also, she had hepatic failure and ascites, renal failure, and an early onset sepsis with antibiotherapy treatment. Throughout the hospital stay, we performed extensive investigations. Baby serologies were all negative. However, we cannot exclude an exotic virus etiology, considering mom's city of origin, which is a cosmopolitan region with international circulation because she was living in London at the time. Her abdominal scans showed ascites, for which we performed 2 paracenteses, and the liquid composition was non-specific with triglycerides and lymphocytes predomination. Also important hepatosplenomegaly accompanied by cytolysis on lab, which subsided but didn't completely resolve until discharge. Fortunately, all the cranial ultrasounds were normal. The baby presented recurrent anemia that required multiple blood transfusions. Direct Coombs test was negative, and blood smears showed a hemoglobinopathy of unknown etiology. So parents and babies were investigated for thalassemia traits, and dad and baby had a heterozygous alpha thalassemia trait. Genetic counseling raised suspicion of Barth syndrome or a metabolic syndrome, but all investigations, including extended metabolic screen and WES, whole exome sequencing, were normal. Baby's management was complex and required various treatment schemes. Respiratory-wise, she had severe RDS and required mechanical ventilation with many extubation attempts, 2 doses of surfactant and non-invasive ventilation. She subsequently developed CLD and, despite also using DART protocol, was discharged on home oxygen via nasal cannula. Because of the severe hyperbilirubinemia, in the first week of life, she received an exchange transfusion and albumin infusions. Also in the beginning, she needed inotropes, vasopressors, several doses of fresh frozen plasma for bleeding, and as volume expander. Her recurrent anemia required a total of 4 blood transfusions throughout the hospital stay. The laterocervical hemangioma grew with baby, developed ulcerations with bleeding, and together with the surgical team, we started prednisone treatment. Soon after, she was transferred to a pediatric unit and the hemangioma was surgically removed. So where is baby now? She is now 18 months corrected age. She has developed almost normally up until this point. She requires some support when walking. She speaks and neurologically has no problems. She is no longer anemic. Her liver function is normal and she has been oxygen free for a year. So what went well? Baby was provided with optimized ventilation, with switching of ventilation modes, including high frequency as needed, which provided a good and constant oxygenation, therefore lowering the risk of IVH and improving the neurological outcome. With adequate medication, baby's high drops resolved and the cardiac and renal functions ameliorated, becoming normal at transfer. However, she maintained some degree of hepatic cytolysis for a few months afterwards. Our unit initiates as quickly as possible enteral feeds, and this helped a good gut development and a low chance of neck. Also, with attentive care of the staff, we were able to avoid pressure sores, muscular wasting, and retractions. What could we improve? Better communication, because not all medical specialties needed for this case were available in the same unit, like cardio, neuro, the surgical team. Communication was often quite hard. We had to rely on our cell phones, and this increased the response time. It would be easier if a number of maternity wards could belong to a specific pediatric unit, so the necessary consults would be done quicker only in the designated unit. More involvement of parents. In the majority of hospitals, the current infrastructure does not allow for such interaction between parents and baby, especially in the NICU. Family-centered care is something to be desired in the future. Better adherence to neurodevelopmental care practices, better incubators that allow for light and noise control, grouping baby's cares and blood draw at the same time are things that need reflection upon, particularly for the smaller preemies. What would we do differently next time? Earlier diagnostic tests. For our baby in the beginning, we had to focus mainly on treating the symptoms because of her extremely fragile state. In the future, we will try to find the cause at the same time as treating the baby. Physiotherapy during hospital stay. Because physiotherapists for preemies are quite rare, we didn't have the possibility to get one to come to the hospital. We will strive to do that for our patients in the future. Explore other viral etiologies. Like I said, we cannot rule out an international rare virus, especially taking into consideration mom's placenta aspect. We could reach out to other specialists and laboratories that process samples for such unusual etiologies. What remains open for discussion? The exact etiology of the hydrops remains uncertain. Although baby had a heterozygous alpha thalassemia trait, the hemoglobin electrophoresis was normal. The Coombs test was negative, and West showed no genetic mutations. We can say if knowing the exact etiology would have changed the medical conduct. Maybe if it was a viral one, we would give specific drugs, although most of them are contraindicated in such small babies. Considering the rarity of the case, it is possible that some microgenetic abnormalities are involved, and surely parents would need genetic counseling and maybe additional tests in the future. At the same time, we should take into consideration that baby developed normally. In the end, I would like to open for discussion an ethical issue. What do you do when faced with such a small and sick preemie, with such small survival and normal development odds in a country where termination of care is not possible? Do you never let the baby die? Thank you for your time.
Yeah, thank you very much. I think, again, a very nice outcome for a very sick baby.
I want to thank Andra for her patience and waiting 24 hours later to present the case. Thank you. It's a great case. In general, non-immune hydrops is a bad diagnosis to have, right? Immune hydrops we can manage easily. Your team did a great job. Outcome is really good. Most of the time it has bad outcomes, when you don't know the etiology for the eye drops.
Thank you. Well, the baby was also a fighter, so there's that.
But that's also our experience. I think that if you can treat these babies, or at least make them survive the first area, then it doesn't come back. So it's really difficult after all to say what was it, because the thalassemia is maybe an issue, but it's not anymore, isn't it? So there's no problem from that.
Yes, I mean, I think at the age of 2 months or something like that, we did hemoglobin electrophoresis, and it was normal. So, and now the baby has no longer has anemia.
And for the virology testing, you said you're not tested for international virus. What do you think about?
Well, we tested, mom was tested in pregnancy, and we also tested the baby for pretty much everything we could think of. Parvo, any virus that's common to our country. And
this was pre-COVID, right?
Yes, pre-COVID, 2019. Yes. Who knows? Maybe she was patient zero.
We had all parvovirus on mind, but this was checked, you said.
Yes, yes.
So because there's also a point in the chat. So David, you want to say something?
Oh.
Because you switched on your camera.
I think NGS, I would be curious. I don't know whether there are studies. New generation sequencing on these very rare cases could be indicated. So if there is some DNA around, it'd be worth looking whether there is something strange in these babies. What do you think? Because it's done now for several sort of rare conditions, and the Dutch has really published in Journal Pediatrics, they had a series of 20 babies very sick on the first day of life. They did the new generation sequencing, and they have been able to identify the etiology in seven of them in not too long a time. So even when I was listening to the previous case and the previous presentation, I always wonder if this condition come with some genetic alteration or not, next to viral, the usual things we always look at it. So I don't know, is worth. Would you Ram, would you offer NGS to this type of babies in your unit, in your hospital?
Not for the ABM, we haven't done that, but certainly in a non-immune eye drops. I mean, the genetics field is exploding. I really don't understand. I just call my geneticist and say, okay, what test you want me to order? And they order it.
So do I. I'm not any smarter on that. Okay.
Yeah, I agree. That would we also do. And in such a case, we would definitely also do a full genetic. And we had 3 babies in the last year where we really found something, and it was not typically correlated with high drops, but actually we still think that maybe we don't know, because we have so many cases of we don't know high drops. So probably with the more genetics, we will know what is the problem.
As far as I remember, there was an old paper, or not a too recent paper. In 42% of the cases, you never come up with any diagnosis. So it's a severely underdiagnosed condition. So, I mean.
So Maren, I also saw you shortly with your video. You wanted to say something? No? Anything?
Sorry, no. I got a message to turn my video on.
Okay. So you're all following what is said to you. That's good. Okay, so we are quite advanced in time. So if there's no further question, I think we could finish. But Ram?
I'd like to thank all the speakers and the panelists and the participants for staying over and participation actively. And it almost felt like we were in real time, at least, except the audience could not ask the questions directly. That's one of the drawbacks of this. Again, I want to thank everyone and also Autumn and the technology team for having a smoother ride today compared to yesterday. Excellent. Thank you so much, and good night, and have a great night or evening. For me, it's a great day to have today because it's only 7 o'clock for me. I will see you all tomorrow. We will see you all tomorrow.
I hope you can go to bed for a while. Take care.
Okay, thanks.
Okay,
Take care.
thank you to all of you.
Bye.
Thank you.
Bye-bye.
Thanks very much. Bye.